all of us.
Thanks, ma'am.
Thank you, ma'am.
Mr. Sunil, you can do the countdown, huh?
We are live.
Very good afternoon to one and all of you. A Sunday afternoon, and we are taking it up for you. We look forward to providing you yet more learning on our daily bread, that is cataract surgical challenges. And we are lucky to have on our expert panel intellects of highest esteem to steer us through the course of this webinar. We have with us our Honorary Secretary AIOS, Dr. Namrata Sharma, who should be joining in any time, who's efficiency incarnate, Dr. Ramurthy, our past President AIOS with his wisdom and quirk, and Dr. Suhas Aldipukar from Mumbai, a surgeon par excellence, a teacher extraordinaire, Professor Titiyal, one of the most prolific surgeons of our country and an academician of the highest standing, and our dear honorary treasurer, Dr. Rajesh Sinha, who's somehow not been able to join in because of some personal commitments. So we have them all to lead us in this webinar today. I have with me Dr. Harshul Tak, who's going to be moderating this webinar. Dr. Harshul is the Chairman Scientific Committee of the Rajasthan State Ophthalmic Society and is also the Chairman ARC Central Zone, a highly energetic, enthusiastic individual. And you watch it, he's going to provide his best moderating ever today. So without ado, we shall go on to our first speaker. Our first speaker is Dr. Saurabh Luthra, who's the director at the Luthra Vision Eye Care Center at Bilaspur, a very skilled, prolific surgeon abreast with the latest in the field of cataract surgery, and he's going to show us a challenging case. On to you, Dr. Saurabh.
Thank you for kind words, ma'am. So I think my video is seen. Can I have a thumbs up on that, Harshul sir?
Yeah, Saurabh, please go ahead. Yeah.
Okay.
Yeah, please.
Yeah, sir.
You need to be a little louder, Saurabh.
Yes, ma'am. So I'll be presenting a case of phacoemorphic glaucoma. As you can see, it has a very shallow AC, a 1.89 AC depth. So I'm starting with a very, very careful side port incision so that I should not puncture the capsule. Blue dye is injected to stain the capsule. I push a little visco so that I have some space to enter with my main port incision, a very precise incision. A very careful small nick is been made there so that we don't expect a sudden gush, because this is a case of phacoemorphic and we have a very liquefied elastic kind of a cortex there. So I'm trying to aspirate some liquefied cortex with the first with the hydro cannula. It doesn't work. Now I go with the visco cannula. You can see those cheesy material coming into the cannula so that I reduce the intralenticular pressure. Yeah, so on the high mag, it is even much more clearer. So I go with my cystitome here because I am very much comfortable doing my rhexis with the 26 gauge needle. But somehow that day is not my day because it's a very fragile capsule, and I am again taking off as much liquefied elastic kind of a cortex by my cannula. So now I decide to open the incision completely with the 2.8 so that I can enter with my Haldipurkar micro rhexis forceps. So I again, try and get back to my rhexis so that I have a fairly all right rhexis. I again go back with my cystitome. The whole key is to be very patient, but it doesn't work. So I have to put a small nick because I don't want to lose my rhexis there. So after this small nick has been made, again I try with my cystitome, but somehow it just doesn't work because it's so fragile, and I am scared of losing it. So again, this comes to my rescue. And yes, as the music changes, my heartbeat also changes, that yes, now we are back on track. It is going well so far. I come back now again, somewhere here it is again kind of stuck. It doesn't want to go. So probably my direction is wrong. My heart is beating faster here. But yes, again, patience is the key. So I change my direction, go down, and then finish it off there. see, you can see how elastic that was. It was so difficult to manage that. But yes, God was nice. My day was all right. And I first go inside with my IA probe to take off as much cortex as I can, again to make space for my surgical phaco probe to go in comfortably. And this will, make my capsule also, my nucleus also mobile. Again, here you have to be very careful because the nucleus is soft, not very hard. I'm a stop and chop guy. I'm very much comfortable here. But again, it doesn't move very comfortably. It takes its own sweet time. So after breaking it, I very gently try and engage the nucleus, bring it
Minute
out,
left.
give a small, chop it, and yes. So that's, again, the game is again back on me. So I feel that now I can go ahead easily, but that's where the patient, kind of moves. So I try to bring it out a little so that, things go much more comfortably and smoothly. So the battle was half won here, and after a nice IA wash, there goes my lens. And I think I've done what I could have done in those available settings with my mindset and the patient scenario. So thank you so much for this opportunity, and I've just cleared the angle so that I don't have any more, viscoelastic stuff there, and nicely hydrated the wound there. Thank you.
Uh, that was a lovely video, Dr. Saurabh.
Yes, ma'am.
Yeah, it is probably, as Harshul would also agree with me, maybe this gymnastics would have not been so challenging if you had made a smaller axis to start off with and then enlarged it.
Yes, ma'am, I have somehow tried that, but somehow in my, my hands, this works much more comfortably. Like after I've made that mistake at times, I've not been able to enlarge it so well. So that's how I, the gymnastics come in between. Keep taking as much the cortex as I can, but very gentle, or rather no pressure onto the anterior so that it doesn't go off. Because in this COVID times, everybody will agree that we've been operating every third case as a mad cat, at least in my part of country. So this somehow, not the making the whole small pieces first. This how works well in my hands. So I've been, trying to do this.
And also pulling the rexis towards the center. That would also keep redirecting it,
Yes,
especially in these elastic capsules.
yes, ma'am.
Dr. Suhas, you are there?
Yeah.
Yeah, I just wanted to know, like, it is possible in these kind of intramuscular cataract to have a rexis extension. Do you actually believe that you had a extension at one point? You would like to make a neck on the opposite side so that there's a better redistribution of forces. Do you believe that concept?
Well, of course, I do. Well, of course, I do. In fact, Saurabh was very lucky and he really managed it well. Can you hear me?
Yes,
Yes.
sir.
There
Yeah.
is some audio disturbance. Sunil, you need to check. It's coming
Yeah, there
in
is.
everybody's audio. It
What?
is coming in everybody's audio. There is some disturbance somewhere. When Saurabh was speaking, it was coming. Now Sir is speaking at that time also, it's coming.
Now it's fine. Yeah.
Now it's okay. Yes, sir.
Yeah. In fact, Saurabh, you really did a good job. It was a difficult one to really get out of it. But then you did say that when you made a puncture and wanted to aspirate, nothing much was coming. So that is probably the time when you would fill in viscoelastic again and make a rexis. But like how Chitra said, if the rexis tends to go on one side, it's better that you stop there, put some dispersive viscoelastic, and go to the opposite end and make a cut. So it kind of balances it, and then you have time to complete it. But of course, it was difficult rexis, and you did it, and somehow managed to get it complete. I think it was a well done job, but the start probably could have been made a little easier by making a smaller rexis. That's what I guess.
I have one other question. It means a combination of a very small eye, a hypomorphic glaucoma. What is the role of a limited past plana vitrectomy being done in these eyes?
I think, Chitra, you have to be very, I mean, I know that glaucoma surgeons, I know Dr. Tanuj does this limited anterior vitrectomy for such cases, but I think it probably has a role, but I think the way Saurabh showed, you can get away with it even without doing a limited anterior vitrectomy, unless the AC is extremely, extremely shallow. Here it was not that shallow, so he got away with it. And I think these cases are very tough and difficult and very well managed case, Saurabh.
Thank you so much.
And one word about Suhas Haldipurkar forceps. It's really, really a
The book,
great tool and a must for everybody to have it in their, tables. It's really useful.
in our unit, yes, ma'am. True. I am a very comfortable Zepto surgeon, ma'am, but this one did not give me the space at least, to think about doing a Zepto there because I have it and I've been really doing it for quite some time. But the AC was so shallow that there was hardly any space for the probe to go in and to be placed and then to play all those gimmicks. So this had to be handled. God was really nice that day to me, ma'am.
Very well managed, Gaurav. I mean, I just have a comment to make that this is one situation where a femto laser really makes a difference. We all know about the cost factor, but this is a truly an indication for using an LRCS. And you, of course, did a Rexis, managed it quite well. But I would, in these situations, more doing an anterior vitrectomy, preoperatively giving glycerol, and even though I may not give a peribulbar block, I make sure my sisters give a considerable amount of massage, about 5 minutes. I do believe that softens up the entire eye and makes the surgery more controlled. And I go through the side port for creating even if I'm needing a needle. And in case I have to extend it further, I would use a microrexis forceps through the side port. I think that prevents the shallowing of the anterior chamber a little more. And when it tended to run off on one side when you are going, I would go ahead and do this brand little maneuver. That's a little difficult to explain by words, but you flip the capsule back and pull it in the direction in which you're tearing and towards the center. That more often helps you to bring it back into the center. I think otherwise you did very well, but I would always go through the side port.
Thank you, sir. I was trying to do that, sir. I was really wanted to do that, but I was so scared of this elastic capsule that I was not sure that if that maneuver in this particular capsule, the kind of fragile it would work.
Actually, it's a little difficult to comprehend, and you don't feel very confident initially. But
Yes.
once you have done it a couple of times, don't go for an extreme situation like this. But even in an earlier situation, if you think instead of it going in a curvilinear fashion, it's going a little straight, then immediately try to do that. You do a few times, you feel very confident with it. And the idea is not only pull it towards, but also towards the apex of the cornea.
True.
Then you find that it gives you much more control.
Yes, sir.
Ma'am, I had a similar patient where we could not even give mannitol pre-op. So we just did a pars plana port and we didn't do actually an anterior vitrectomy, but just vitrectomy at the tip, at the edge. And that itself helped to reduce the intraocular pressure and the chamber could be deepened well. So maybe that is one more thing we can do. Because it's a blind procedure and you cannot actually do a vitrectomy without, there could be a damage to internal structures. So this was something else.
So can I add a quick comment, sir?
Yeah.
Yes. The basics, what we generally have to follow is keep the flap flat. Each and every time, inject OVD, make the flap flat, catch the flap at the very near to the tip of the rexus margin and not away from it, and try to make smaller sized rexus in such cases. But I don't know if pars plana vitrectomy will help because it is raising intralenticular pressure than IOP. Of course, IOP is raised. This phacomorphic glaucoma, but
I mentioned it's a very small eye. That's all.
Yes.
That's all.
So this may help. Thank you.
Harshul, you have anything to add?
No, I think Saurabh managed it very well. Only thing is that in intumescent or pediatric cataract, when we are doing capsulorhexis, I think the microcapsulorhexis forceps, as Dr. Ramamurthy also said, it's very helpful. I don't think that we should try to do with cystitome because the radialization chances are very high in these cases. So always try to do with the capsulorhexis forceps so that you can change the direction whenever you need. You can use all the, different kind of maneuvers. Very well managed, Dr. Saurabh. So I think let's move on to the next case, ma'am.
Can you introduce the next case?
Yes. So it's my pleasure to welcome Dr. Vivekanandan. who is a dynamic surgeon from Arvind Eye Care System, Pondicherry. And he'll be presenting a very nice case showing multiple delineation in phacoemulsifications. Dr. Vivekanandan, can you hear us?
Yes, sir. Yes, sir. Yes.
Yeah, please share your presentation.
So, good afternoon, everybody. I would like to thank Chitra Madam, AIOS-ARC for giving me this opportunity. So today I'll be presenting a series of 3 cases, but all same type of cataract, but different scenarios. So as we all know, the most challenging cases for us is either the very, very hard ones or the very, very soft cataracts. So today I'll be showing 3 cases of soft cataract. So this is case 1. So the problem with soft cataracts is it is very difficult to chop them, to crack them. So the main problem we have is we have a lot of cheese wiring happening, and then we end up having a central bowl, and removing the peripheral part of epinucleus and the cortical matter becomes difficult. So what I prefer to do is I prefer to do multiple hydro delineations. So 3 to 4 delineations, then I start from the center, remove the endonucleus, and then remove layer by layer. So this way, there is no need for going in with your stop and chop setting or your chop setting. So you don't debulk the central part of the nucleus. Instead, you kind of create multiple layers, remove them one by one. This is a little easier. This is a real-time video, just a few seconds and it is done. But once when we try to chop or try to do a divide and conquer, we end up having a lot of cheese wiring, and the rotating of the nucleus, everything becomes a little bit of problem. So the second scenario is it has a preoperative posterior capsular tear, as you see. So this was a young patient with an old history of trauma. So what I wanted to do was I gave IV mannitol to this patient so that the vitreous becomes a little dehydrated. Partial hydrodissection was done because I could identify the PC margins. Then multiple delineations was done. So by doing multiple delineations, I kind of loosened out all the epinucleus and the central endonucleus. So the main idea of doing this is debulking. So if at all the PCR extends, I do not want anything falling inside. So the main idea was debulking. And most important part is all the parameters are lowered. No, I do not go in with my phaco setting. I do it with my epinucleus mode setting. So epinucleus mode, like I have an aspiration of 38 fixed, 350 vacuum and power of 40. And this is the most interesting part. When we know that there is a preoperative PCR or we are expecting something, it is very important to leave the last part of cortex outside. So what here I'm trying to do is I'm trying to separate the cortex from all quadrants before centrally aspirating them. So even at this point, even if you have a little bit of vitreous disturbance, there will not be any cortex drop or loss of nuclear material into the vitreous. So even vitrectomy can be done and IOL can be placed. So in this scenario, we didn't have any vitreous disturbance. Since we had seen the PCR preoperatively, we gave IV mannitol, it kind of helped. And the third case scenario, this is a PPC case. And once the rexis was done, we could see the posterior capsular tear extending from in the center. So what we did was we avoided any part of any type of hydrodelineation, the same concept, 3 to 4 times multiple hydrodelineations was done. And then with the lowered phaco parameters, very little fluid going into the eye, gently it starts from the center and then removed peripherally. So layer by layer, all the soft nuclear material is being emulsified. So once that part was done, so once the layer by layer removal of the epinucleus is done, we are left with the last part of the epinucleus. So in this part, if you try to aspirate, it's going to be very difficult because it's all sticking together. So I prefer doing a viscodissection. So gently separating the epinucleus and cortex from the posterior capsule. So at this point, you can see there is a little bit of vitreous disturbance. So most important thing is before removing your probe, try to flatten out the epinuclear plate, inject viscoelastic. And I prefer using a Simcoe or a bimanual aspiration. So Simcoe is always underneath the plate so as to prevent it falling posteriorly. And once the cortex floating in the antechamber is removed, a little bit of central vitrectomy is done. And then the IOL is placed in the bag. Or in a 3-piece IOL in the sulcus. Since the support was adequate, I preferred placing it in the bag. But ideally, 3-piece IOL with the optic capture will be best. So take-home message will be multiple hydrodelineations in cases of soft cataracts. In case of cataracts with PC dehiscence or anticipating any PC dehiscence, it's better to give IV mannitol or oral glycerol, like Ramamurthy sir said previously. Thank you.
Thank you very much, Dr. Vivekanand. There were a lot of pearls, not just one pearl in what you said. So the only thing I wanted to ask you, it seemed to be quite perfect. Supposing you have a hard cataract, you know, these multiple hydrodelineations will not be so effective. So would you believe in doing an inside-out hydrodelineation in that particular case, or how would you approach that?
Sometimes we end up having a hard endonucleus, madam. In that case, I prefer chopping it. But the main idea is to keep the peripheral parts loosened. The central part is pretty much easier to emulsify, I feel. So to keep the peripheral parts not cheese wiring or becoming a ball or clumsy, so I prefer doing a lot of hydrodelineation so that I can remove layer by layer.
Irrespective whether it's a soft or a hard cataract?
No, madam. This is just for soft cataracts.
That's what I was asking.
So if I may just intervene, Chitra, layer by layer technique of phacoemulsification was described in 2008 by Professor Vajpayee for posterior polar cataracts.
Yes.
And at that time we never had a femto. So I think very well extrapolation of that for soft cataracts, especially to prevent cheese wiring. So of course, with again, Dr. Ramamurthy will say, and I would agree, and all of us, that for those with posterior polar cataracts, probably femtosecond is a better option because you can make cylinders and blocks and grids over there.
And also these multiple layers actually protects the capsule, more importantly, besides the ease of removal, because all the intralenticular pressure or the forces of in this area operation is not transferred to the weak area of the capsule. So that's what can be done with the Lensex platform of femtosecond laser, where you can create multiple cylinders, and thus you have layer by layer, as you were trying to do. Any other question, Harshul?
Dr. Vivekanandan, what gauge of the cannula do you recommend to the the younger surgeons, and which type of cannula they should use for these multiple hydrodelineation?
So we use a 26 gauge cannula. The smaller cannula, the better actually. We kind of get when the cannula bore is a little wider, what happens is you cannot get so many delineations. It kind of you get one or two. That's all. So the main idea is as many delineations you have, it is easier to remove it layer by layer. It is easier to see where that part of the epinucleus or endonuclear ring ends. So you can, even if it's not coming with your vacuum, you can gently scoop it out with your Simcoe or spatula.
Yes,
absolutely.
As usual, very well done, Vivekanand. I mean, exquisite videos. But just a couple of observations. One message I would like to send across is that, I also believe that, if you have a PC rent, also if you have a round pupil and a round rhexis margin, you can assume that vitreous is not there. But like the last case you showed where you beautifully put in a lens inside the back, but there's a large rent. I'd always recommend in today's world that you put in a little bit of triamcinolone, diluted triamcinolone acetate, and just make sure there are no strands. I'm quite sure there was nothing, but it's always a good idea to ensure. And sometimes I'm surprised that even in these very simple cases, you find a couple of strands and you can deal with them right on the table instead of having to deal with it later on. And second observation that I have is that, you had a situation where some of these cases I found that though the hydrodelineation wave was passing right through underneath, I would like to avoid that in even if I'm doing segment by segment. And there's a lot of talk about this AIOS-ARC in posterior polar cataracts. Are you doing it in your centers?
Yes, sir. For all posterior. Yes, sir. For all posterior polar cataracts, we do AIOS-ARC. So with cases where dehiscence is there, we try to give oral glycerol, if the physical health of the patient is good, we prefer to give 50 ml of mannitol, IV mannitol before surgery. One interesting find, sir, not all patients where AIOS-OCT shows PC dehiscence do not have posterior capsular rents. So that observation, almost like 40%, there is no PC dehiscence on table, but AIOS-OCT suggests PC dehiscence. So I think we still are studying that more precisely.
So I think that also occurs because it depends on what AIOS-OCT you are using. So if you use KCR2, which has got a higher resolution and picks up the PC much better, then probably the chances of picking it up are much more as compared to if you use a normal kind of a AIOS-OCT. I think also you need to qualify in your soft cataracts is the settings. I think settings are important when you're doing soft cataract.
Yes.
Very good point, Namrata, and I tend to agree with Vivek in the sense that, if you find that there is a PC rent and you suspect it, sometimes you're pleasantly surprised that it is not there. But if you feel that the PC is intact, the OCT shows that the PC is intact, it is intact. I mean, on the table, you don't find that it is, you're faced with a surprise. So that way you have to qualify your observation that manner.
But it was yes,
Yes.
Dr. Kashyap.
I have an observation. Nowadays, finding a pre-existing PCR in the era of anti-VEGF injection is on rising. So I have got a lot of a series of such cases. And in my experience, what I do in these cases, especially these cases, I've got a hard cataract. So what I do is I enter the anterior chamber, put the visco, and then I go into the posterior chamber, pars plana, put the trocar cannula, do a little bit of anterior vitrectomy, put my irrigation, and titrate the height of the bottle so that it just maintains it. So what it does, it pushes the nucleus upwards, and you are little on the safer side. And you know that the nucleus is not going to drop down very easily because there is some thrust from inside pushing the nucleus towards the anterior chamber.
Dr. Suhas, you have anything to add? Dr. Suhas, are you there?
Yes. Talking about that case, like Ramurthy said, it's an excellent demonstration of a lovely case, especially when in both the cases with PCR, he could manage to get the single piece in. I mean, that is something which, you really need to be good to do it.
Yeah,
So Vivekanand, I was very impressed with that. Because part of, quite a tear from one end to another end, you were so confident to get the lens in the back. That was amazing.
Yeah.
Very well.
Just an important point for the listeners that we need to be very careful when you're inserting a single piece in the bag. You need to flex it very gently and ensure that you won't overly stretch the bag. Inject enough viscoelastic and go ahead and do it. You have anything to add, Dr. Vivekanand, before you go on to the next speaker?
Thank you, madam. Thanks for this opportunity. And Ramurthy said, I will take that point. I'll use tricot regularly from now on.
Also, I think one does need to know, especially in case of traumatic cataracts, whether the pre-existing defect is intraoperative or was it pre-existing. So if you could just highlight upon the points which suggest that it is pre-existing or has occurred intraoperatively, I think that would be important again.
Yes. Thank you, Dr. Namrata. Harshul, would you like to introduce Dr. Priyadarshi because he needs to go in earlier? Yeah.
Yes, ma'am. So it's my privilege to welcome Dr. Priyadarshi Asnani. We all know he's a very versatile surgeon. He's from Gujarat, and he's going to show us a case of customized toric IOL. Dr. Priyadarshi?
Yeah, thank you, Dr. Harshul. Thank you, AIOS, for having me here. I would keep my video off because of signal problem. The case I'm showing today, the patient had a history of 15 years back.
We can't see your video, Dr. Priyadarshi. You have to share your video.
He needs to stop sharing. Dr. Vivekananda needs to stop sharing the screen.
No. Vivekananda is not sharing.
Not sharing.
Dr. Asna, now.
Right.
Yeah. Okay. Yeah. So this patient had history of trauma 15 years back. He has a corneal scar on superior limbus, which is giving him 13 diopter of astigmatism. You can see the distorted mire. This is the other eye of the patient. This is a topography showing 13 diopter. Astigmatism was quite regular in this case and quite stable. So routine toric IOL would give us almost 7 diopter residual astigmatism, and we thought of going ahead with this customized toric. So surgery was done in routine manner, and here we are implanting this 18 diopter of lens on IOL plane. So the case actually starts now. So as soon as I started pushing the plunger, I felt something unusual, and I decided to, inject it outside and see. And this is what it happened in the plunger. This is this cartridge and everything was provided by the company. So we have damaged this one side haptic. So we are reloading the same lens in a bit wider bow cartridge, again provided by the company. And now we are off the surgical site actually, because we were just struggling and doing some juggleries here. So again, I thought, and there was some unusual feeling, and I thought of just injecting it outside. And this is what again happened. This time the cartridge gave away. So the cartridge was, there was kind of a dehiscence in the cartridge. So, and this time the very haptic was broken. So this is very popular cartridge, we all know. So we thought of using this as this is a C cartridge. So I'm just trying to implant this lens with this cartridge. Again, we are doing it everything outside, and you saw it was quite uncontrolled. And finally, the B cartridge, and I feel this is a jack of all. So let's see. So this time it was quite okay, and good thing this IOLs are in always pairs. So we had one more IOL of the same diopter, which was then introduced in the B cartridge. We had, of course, we had to increase the incision size, and of course, with bit difficulty, we were able to manage this case. So again, we were a bit stuck here, but we got away. So this was the case. So idea is not just thinking of something, but take this to end is even more important, and sometimes it's very unpredictable. This patient was given lots of other options at other centers like LRIs and all. But I think even bioptics and other things, but with this simple solution, we could do it. So removing the viscoelastic and doing my job. This is post-op, 3 months. This is well-placed IOL, and this is what we end up with. And I think this was, patient was also very happy. Thank you so much.
Thank you, Dr. Priyadarshi. That was a wonderful insight you gave us about when we contemplate using customized toric IOLs. What was the formula which you used when you did this particular case?
Madam, this was done almost a year and a half back, but right now we are calculating everything on Barrett's.
Barrett's, yeah. So then the only, as you said, that whenever you're stuck with such high cylinders or high parts, it makes sense to use a customized IOL, or probably you could use a high powered IOL in the bag and combine it with a piggyback Sulcoflex lens in the sulcus. So that would be the option. And of course, as he said, we need to be very clued on that these are large IOLs. You have to increase the incision size and use a larger cartridge. Expert panel, what any opinion of yours? You would like to add anything here?
Chitra, I would like to add that Priyadarshi has highlighted an extremely important point.
Yes.
Very often when we ask for customized lenses, especially for hyperopic eyes, I mean non-ophthalmic eyes or such cylinders, the company people fail to deliver us a cartridge which can accommodate that particular lens. Now, especially this lens with 18 diopters cylinder, obviously that lens is going to have thickness in one axis. So the standard cartridge will never be okay for that. But this insight the company people should have, and that's the reason they probably send you 2 lenses. But that's not enough. The kind of trauma that you go through, because till that lens is gone in, you're not at ease. So I think, like you said, probably we have to use their lens and maybe use the widest cartridge that we have in our basket, and maybe through a 2.8 or 3 millimeter we put it. I think that's an excellent point out of his, Priyadarshi, congratulations, and nice.
Thank you, sir.
Yes.
Thank you so much, sir.
And one more thing, that whenever you face resistance like this, as Dr. Priyadarshi has shown, you should be careful that there's definitely a mismatch in the lens and the nozzle of the cartridge, and you should not try to push it.
Yes.
I think
This lens is from the.
Yes.
Pehle aap.
This lens is from the Care Group company, right? So
yes,
they have their hydrophobic lens, the acryol. So they have that MDCL cartridge. So if you use that, especially for the higher powered lenses, then it goes in very easily. You could have used that also. That could
provided. They don't give you that cartridge.
They don't give you, but if you could have asked for it, because like sir said, it would be a very thick lens, so it goes in very easily through
broke.
So I think this is a problem with the, I shouldn't say with the Indian cartridges, but yes, the cartridges that we do get from companies which are in India, this is a problem. And they tend to, like Dr. Asna showed very nicely, how that cartridge only split. So that this happens if you, use it again and again. Even sometimes happens also when you use it for the first time. It is not a very rare phenomena that way. And I don't know, like what he did. I also do the same thing. Whenever I fail to, put a lens, I just take it into the auto cert in the cartridge and then just put it. I mean, it is the easiest way to do it. Of course, you have to have cartridges from the other company then to allow you to put these lenses.
And more on the part of the patient counseling, whenever we're dealing with such high powered IOLs, we should be prepared for some refractive surprises to happen. So we need to inform our patients that we might have to do a secondary procedure if we want to try our best to get to target emmetropia. So shall we go on? Any more?
Just a couple of points. I mean, the sense that what Anaga said was the point I wanted to make, in the sense that they do give MDCL cartridges with this extreme powers. And usually when they make these customized lenses, they don't make one of them, but they make 3-4 of them. So not just 2, you could ask for 3 of them also, because at no extra cost, generally they supply, because, there are always chances that you could split these lenses. And secondly, that, when you're, it's not only when you're injecting the lens, as Harshul pointed out, you feel resistance. When you're placing the lens in the cartridge and trying to close the cartridge, and if it's not closing easily, if it's jutting up, that itself is an indication, because these lenses are about 1.3 millimeters in their thickness in the center, while most 20-21 diopter lenses are about 0.7 millimeters. So that itself tells you that it is not going in right way. One of the cartridges, as you rightly showed, the B cartridge, which needs a incision of 3.2 millimeters, is one versatile cartridge in which most lenses can be passed through. So whenever I'm faced with a difficult situation, I resort to that. And of course, make an adequate incision. Don't be trying to make a 3 or wound-assisted implantation, an adequate incision, and then these lenses go in. There has been an extreme situation where I made just a 4 millimeter straightaway incision, just squeeze the lens through the incision itself without using any cartridge at all. The edges just fold up and the lens goes in. So that also is a possibility that you can consider in these extreme cases.
Sir, in such cases, then, since we are putting a toric lens, what would we consider as the SIA? Because routinely, then the SIA would be for a 2.4 millimeter incision. Here, when we are extending it up to 3.2 or say even 4, then would the calculation change?
He had a minus 18 diopters and he was again with minus 2. Maybe if he had made a 4 millimeter incision, even the 2 diopters would not have been there.
That is been very optimistic now.
Yes.
So good, Dr. Priyadashi. You really brought
Thank
up
you.
a thing for discussion. So we shall
Thank
go
you,
on
ma'am.
to our next speaker. The third to follow is another super surgeon who heads the center of Agrawal Group of Hospitals at Tirunelveli branch. And it was interesting to note that he dabbles into a whole lot of subspecialty practices besides a cataract. So let's hear this dynamic guy show a case of his with its own learning tip. On to you, Dr. Lionel Raj.
Thank you so much, ma'am. Is my screen visible, ma'am? Toric trifocal
Yes.
implant.
Yes. Yes, can you start?
Yes, ma'am. 1 minute. A 44-year-old male with dense posterior subcapsular cataract was taken up for a cataract surgery with toric trifocal implant. An online toric calculator was used with Barrett's formula. Based on flat meridian of 135, steep meridian of 45 degrees, and IOL spherical equivalence of plus 22 diopters, a TFNT60 model of IOL with 43 degree fixation was planned. After a microphacoemulsification, a toric trifocal IOL was successfully placed and aligned at 43 degrees, the desired axis. The viscoelastic substances were removed completely from the bag and the surgeon was happy after a successful centration of the lens. Perhaps the patient was not happy. On postoperative day 1, there was a refractive surprise of plus 3 diopter sphere and minus 7 diopter cylinder at 45 degree with IOL in the specified axis, position of 43 degrees. Warren Hill has described 4 possible errors with misaligned toric IOLs, of which interchanged axis is an important source of error in our case. The options left for me were rotating the IOL or exchange of IOL. I proceeded to rotate. An online toric results analyzer was used. After marking the originally placed IOL parameters and the amount of refractive residue, the results were obtained. Rotating the toric IOL 87 degree clockwise to a newer axis of 136 degrees was expected to correct up to 4.5 diopters of astigmatism in this case, and a residual 1.87 diopters of astigmatism was anticipated. The patient was then taken back to the OR as early as on day 3. The new axis of 136 degree was marked manually. The incision and the bag was opened up very easily as they were fresh. With adequate OVD, the mobility of the IOL was then ensured. After sufficiently filling the anterior chamber and the bag with OVD,
1 minute left.
the IOL was gently rotated to the new desired position of 136 degrees with maximal ease. Following which, the viscoelastics were removed and the wounds were secured well. The postoperative day 1 and after 2 months, the residue was less than a diopter of spear and 2 diopters of cylinder as predicted. By 2 months, a surface excimer ablation helped in achieving 20/30 N6 vision with no residual refractive errors, and the patient was happy. To conclude, toric IOLs with or without multifocality are sometimes associated with misalignments. Accurate planning and verification of axis are very important. Interchanged axis was a blunder in our case and required and early resurgery. Use of online refixation calculators ensure toric IOLs are forgiving lenses and not necessary to be exchanged.
That was a good one, Dr. Lionel Raj.
Thank you.
Now, in your experience, this was done within a week, right? This
Yes, ma'am.
particular care.
Mm.
So how late have you tried to rotate your IOLs?
Generally, yes, ma'am. Generally, toric IOLs, even as advocated by American Academy, we need to wait for at least 7 days generally before refixations. Whereas in this particular case, since it is transposition of axis, and either I have to remove the lens or rotate to a newer axis, which is beyond 30 degrees of originally placed axis. So I decided to go ahead at the early stage, because once if the fibrosis or adhesions occur, then I may be challenging the bag as well, the zonules. So that's the reason I thought of going ahead very early.
In which kind of a scenario would you have thought of an IOL exchange altogether? Here, of course, it made sense because it was a error on your part. But if this was not that, would you have considered an exchange in its place?
Yes, ma'am. That was number 2 option in my mind. The very reason why I wanted to present this for the audience is also toric IOLs need not be exchanged all the times.
Yeah.
There are ways that we can still retain the existing IOL, reposition them, and with the help of bioptic procedures, we can still retain the forgiving lens. There are sometimes where if the power calculation itself is wrong, the spherical equivalence, then all those are the situations I would have gone for exchange.
Anything to add from the expert panel? Dr. Suhas, Dr. Ramurthy?
I think, Lionel, I mean, are you using a digital overlay?
We have, sir, but this is this was done little earlier.
No. The reason I'm asking this is, your rotation was by 90 degrees, and that's too extreme. And that's the reason you did it on the first post-operative day. If at all rotation is needed of these toric IOLs to a small extent, what is recommended by the American Academy, what we also follow, is about at the end of 2 to 3 weeks. But that's when the main wound is healed and the astigmatism is quite stable. And then not in the first week, 2 to 3 weeks later, you rotate. When you have a 7 diopter cylinder left over, like in your case, obviously it's better to intervene quickly. The reason I asked whether you are using a digital marker is, like in the Varion, you have a overlay which tells you the toric axis. At 90 degrees to it, you have another dotted line, which is slightly. Once I did a mistake of, in my hurry, just aligning it with that line. And that's the reason the lens was malpositioned by 90 degrees. But obviously, otherwise, if you're using a manual marking, getting a misalignment by 90 degrees is something which is very surprising. And the lenses don't also rotate that much. And secondly, I know you are a fantastic surgeon and you're a very good friend, but I'm going to be pretty harsh on you. I believe that you didn't do much for this patient at all. You started with 3 diopters of cylinder, and with all this gymnastics, you left him with 2 diopters of cylinder, which had to be taken care of by laser vision correction. Something wrong with the calculation, something wrong with what was done. I mean, this is not a normal results. I mean, I don't know whether your initial IOL power calculation is something wrong with that.
So that's what I was telling, sir. It is the interchange of the axis during calculation. It is a manual error.
No,
That's
but
what
It was a
I'm trying to
manual
tell.
error.
what sir is
And
saying,
it wasn't, he had not 3
It's not the
diopters, he had
rotation.
8.
No.
Yeah,
but he had a residual of 2 diopters. No, that is
Yes,
what sir is
residual.
saying.
The
Why
residual
was
of
there
2.
a residual?
I got
Yeah.
it, but it's a blunder.
Yeah.
I do agree. It's a blunder. I didn't want others to do, because it's most often we just go ahead with the optometrist working for us.
Yes.
This is a learning case for me. After this, each and every toric case, I verified my own with a preoperative op scan as well before
what
calculation.
I'm trying to say is, I myself I did this blunder once, in the sense that I aligned it with the other line, and then I had to go the next day and found that it's 90 degrees off, because I was using a Varion toric overlay. But after you did the rotation also, you just reduced the preoperative cylinder by 1 diopter. I mean, this patient was still left behind with 2 diopters of cylinder. That's not something that we normally experience.
Yes, sir. But that was predicted by Burdle-Hatton axis refixation.
So that's when, you know, you use the Barrett RX formula, which gives you 3 alternatives: whether to rotate the lens, whether to put a piggyback lens, or exchanging the lens. What's the new IOL power? So you have to look at what's the residual power, and if it's 2 diopters, the cylinder is going to be left behind after. You
would have got it out.
Yeah, I would have exchanged the lens, not just rotate the lens.
Got it.
Can I add one small point, ma'am?
Yes.
Dr. Lionel,
yes.
You showed when you were rotating the IOL, you again marked the reference axis, no? And then you marked 130.
Yeah.
There's another way, you know, which we can do is like the lens, it required 87 degree of clockwise rotation. So you take those toric marks at 0.
All right.
And you do 87 degree clockwise, because then you know, you don't get that 4 to 5 degree of error, which can again arise because of the reference axis
got it.
marking. Yeah,
the point
that's
I
another
want to make is this is the case not for rotation but for exchange, because, you know, even after the rotation, it was showing a high amount of residual
2 diopters.
Yeah.
Yes.
And sir, any tip on, you know, I mean, okay, whatever happened, but, you know, handling the patient also with all this, you know, premium lenses?
No, only thing, because these are older patients, by doing the biotics, we need to be concerned about the dry eye status about these patients. So we need to be prepared that we need to use lubricants for a much longer time. That is one extra point.
Yes, ma'am. And to answer his question exactly, the patient is not very old also. He's a middle-aged man. I accepted the first post-operative day only. I accepted the fault to him. I said, this is something wrong with my calculation. I will try to get the best from me. The patient was from Trivandrum. He's such an excellent person. He really cooperated to all the procedures. I'm thankful to the patient also.
Good. That was a good learning video. So then, shall we go on to the next speaker? Harshul, would you introduce?
Yes, ma'am. So next we have none other than Dr. Anaga Haru, who is also member ARC from West Zone, a brilliant surgeon, cataract and refractive surgeon, who is the director of Anil Eye Hospitals, Mumbai. Dr. Anaga, over to you.
Thank you, Dr. Harshul. Am I audible and
Yes.
visible? Yeah.
Yes, we can see.
Yeah. So this is a case about an 8-year-old boy who came to us with history of trauma with a ball, and he had traumatic cataract and an iridodialysis. So we first did a peritomy inferiorly in the area of the iridodialysis and marked a 1.5 millimeter along the inferior limbus in the area of the iridodialysis and made a partial thickness scleral groove. Then 2 side ports for the irrigation aspiration and 2 side ports for the retractors. We put in a little tricot just to confirm that there was no vitreous. And then we pulled up behind the pupillary edge so that we could go ahead with the lens aspiration. Then we went ahead with the capsular rhexis. So this was it was so important that this should be perfectly circular and perfect rhexis. So fortunately we got that right. And then we took an incision 180 degrees exactly opposite the area of the iridodialysis. A very gentle hydrodissection was performed. And then with the bimanual, we did a lens aspiration. Since it was a pediatric patient, it was very easy and with very soft new material, and that was done. So once this was done, as you can see, the pupil was retracted there because of the iris retractor. And because it was a history of trauma, we thought it would be better to put in a CTR also, just in case there were some loose zonules, because this was a pediatric patient. So we put in a CTR in the capsular bag. And then after inflating the anterior chamber, we put in a 3-piece intraocular lens into the capsular bag. So once the lens was well centered and dialed in properly, the iris retractors now were removed. because now we had to go ahead and do the iridodialysis repair at the same sitting. So the iris retractors were now removed, and the viscoelastic in the anterior chamber was then aspirated. We then put in pilocarpine so as to constrict the pupil. Now, in order to do the iridodialysis repair, we were deciding between a 30 gauge and a 26 gauge, and we found that the 90 proline went in well through the 26 gauge needle. So now we used a double armed straight needle of the 90 proline and a bent 26 gauge needle through the partial thickness scleral groove that was done earlier. And by railroading technique, the iris was then sutured to the scleral edge. So we did it in 2 sittings. So this was the first part, and this is the second needle that is going through now. We had to be very careful each time we put in the 90 straight needle through the main incision. So we were opening it with the McPherson forceps because it can easily go through the corneal tissue, and that can cause an issue. Once this was done, then so we did it with the second knot, and both the knots were then later on tied simultaneously so as to have a good approximation of the iridodialysis edge. And once this was done, we tied the knots on each side very gently and not too tight and not too loose, so that both of them could approximate the edge perfectly. The pupillary edge was also then adjusted, and we saw that the knots were buried in the partial thickness scleral groove there, so that the ends would not irritate the patient. So both these procedures at the same sitting was attempted here. And once this was done, the pupillary edge was then adjusted, and the main wound was also sutured with 10-0 ethylon single suture. And the case was done with just confirming here that the knots are buried, and the peritomy also was sutured. We could have also used glue here, but we used a suture here to close it. At the end of the surgery, the patient did extremely well. This was the end of the surgery, and the patient improved to 6'9", and this was the patient. Thank you so much for kind attention.
That was a
Amazing.
wonderful presentation, Anaga. A lot of learning. But just for the sake of an argument or a discussion in your case, why would you place a CTR? It's not like a prophylactic medication which is given, because your rhexis was quite centered, and so you could have anyway, if you had come across a dialysis, you could have pushed in a CTR at a later point, and by the time you decided to put it, the whole cortex was out, so it was a clear bag.
Yes, ma'am.
And
I agree. There was no dialysis.
No need dialysis.
Yes, yes.
Yeah, that. And a tip for the beginners who are watching this video. Of course, you know where to locate the incision in the area of the dialysis, but how many handbag sutures would you like to place, and how would you take your bite through the iris? Could you highlight that?
See, ma'am, here it was quite a large iridodialysis. So with only one suture, obviously it would not suffice. So that is why I decided to take 2, and 3 would have been too much. So that is why I marked it with the ink before we actually did it, and I had planned it pre-operatively also, even when I had taken the picture on slit lamp. So I had marked it so that once we took it, we found that it worked well.
And how do you hold the iris tissue so that it doesn't cut through?
So we used micro forceps. Micro forceps we used so as to put it. And in fact, I did not want to put in the 26 gauge needle through the iris. That's why I put in the 90 proline needle instead of the 26 gauge, and then railroaded it through the 26 gauge needle, because I think the bore of the 26 gauge is much higher.
Ashwin, you have anything to ask?
Yeah. Dr. Anaga, very nicely managed. I think it's a perfect teaching video how to manage the case of with iridodialysis. Have you tried different methods like sewing machine technique or the modified sewing machine technique also to repair iridodialysis?
Yes, but in this case, I thought this worked well, because since it was a child and 2 sutures itself would suffice, and I didn't want to go in and out too many times. So I thought this would work well in this case. There are various ways that you can do it. If it was only an iridodialysis repair, then probably we could have done that. But I thought this would work well in this case.
Anything to add, Dr. Suhas?
Yeah. Well, Anaga, very well done. But then I'm sure while you're doing it, you must have noticed that when your 9 goes to the main opening, your needle holder or whichever forceps instrument you're holding, it cannot hold the needle very steady. And that's the reason if you can use the AC maintainer trocar, which is devised by
Yes.
Dr. Amar, and if you put it through a small side port, and every time you put your needle through, if you use that trocar to push in your needle, the needle stays steady, and through a properly adjusted side port, if you go with a micro forceps to hold the peripheral edge of the iris and just push it through. And in such cases, even if it's 2 or 3, I still prefer to go for cobbler's technique or sewing machine technique. That's how you don't have to every time come in with your 26 number needle from periphery. You all the time going with a 9 out and in, out and in. And if you can hold on with the forceps to the extreme edge of the torn iris, then before you tighten the suture, if you take the viscoelastic out and get your pupil well centered, even at the end, the pupil continues to remain centralized without a small peaking. But you did a good job. But for someone who wants to do it for a larger case, you have to be very watchful about the peaking of the pupil on one or other side. And that can be avoided if before you tighten the suture, get the viscoelastic out, get the pupil, use your forceps to pull on the pupillary edge to get it in the center and then tie the suture.
Right.
Thank you. So we shall now go.
Just
Yes.
one superb surgery and great points. Suhas, that point about trocar is truly, I think it's a great thought. We'll try it out the next time. I mean, another great surgery. Just to add a point, I mean, the last suture when you tied, the tension of the suture I might have adjusted a little bit because I found that there was a little peaking, just to make it even more perfect. And to play the devil's advocate, why not a multifocal intraocular lens? You did such a good surgery, 8-year-old, the refractive error is quite stable, the eye wall growth has already occurred, and this is not going to have a progressive subluxation. Why not a multifocal intraocular lens in this? Why banish him to a use of bifocals throughout his life? I mean,
Yes, that's
Sir, his eye pressure was also on the higher side, plus it was a traumatic cataract, and definitely there would be PCO. So I didn't want to complicate matters even more. That is why
I'm just putting this
had
thought in the
explained.
sense that,
And
in these patients also, nowadays we are veering around to the view that we can, even monofocal and in monoocular cataract, but where you expect the capsular back to be very stable. Actually, there are surgeons who have started trying out multifocal intraocular lenses with reasonably good results. The present day lenses allow you to do that.
Okay.
Yes, sir.
Thank you. Definitely, that's a food for thought. I mean, we are concept of getting great vision for all ranges of vision. The distance is important. Our next surgeon of repute is Dr. B.P. Kashyap, who heads the Kashyap Memorial Eye Hospital and has created a impression amongst the masses of Jharkhand with his yeoman services to his community at large. He would be showing us a case with a great learning tip. On to you, Dr. Kashyap. Dr. Kashyap? Yes.
A case of penetrating injury by object entering from the center of the cornea to behind the iris and then to the limbus with traumatic ruptured cataract with irregular margin of capsule. Trocar cannula inserted first without corner stitch. After one stitch, the other trocar cannula were inserted to facilitate pars plana vitrectomy. To make the rhexis complete, smooth and regular, we tried 26 gauge needle but failed, tried Uterata forceps but failed, used Vanna scissors but failed because the capsule was floppy. Then we used lancet knife and it did the job. We found the plane and could complete the rhexis properly. We asked for the chandelier light, but the tip got broken. Continue with the broken tip. It was held by the assistant to show different quadrant. On B scan, we had found to have a suspected intraocular foreign body. This is a kid of 12 years, so there was no problem in doing IA to remove his cataract. IA was complete. Then we inserted 3-piece foldable IOL in the bag. Then we performed pars plana vitrectomy, a core vitrectomy, and we did not find any foreign intraocular foreign body. And after the completion of vitrectomy, we injected intravitreal antibiotics. Air was injected in the anterior chamber. Incision site was hydrated, and BCL put no stitches was given on the incision site. So our highlight is we should avoid central stitches as much as possible to avoid high degree of astigmatism. Even the broken Shannon light tip can do. The lancet knife entering the capsule can give you a plane to complete a good rhexis. Air, BCL, and wound hydration is enough to avoid stitch in young children. Thank you.
Thank you, Dr. Kashyap, for bringing out different points. But I do have a controversy here. Maybe I've not used a lancet knife, and I'm really not sure that this capsule could not have been handled the regular way which you would deal with an elastic capsule. Dr. Namrata, are you there?
Yeah, I am there.
Yeah. So I just wanted to ask you, Namrata, what would you advise in these cases where there's a corneal wound also about the suturing? Would you try, if the incision, the break in the cornea, tear, extends into the visual axis, how would you advise suturing? Would you tell them not to suture in the central area where the actual visual axis is passing through? That's number one question. The second question is, wouldn't you advise a corneal tear repair to be done primarily? And if the anterior capsule has not got injured, wouldn't you ask for a IOL implant cataract surgery to be done in a second sitting?
So I think some of the points I agree with you, Chitra, in the sense that if there is a perf like that, then best it is to repair that perf. And when you're putting the sutures, you have to be a little careful in the sense that you avoid visual axis, even if the sutures are a little non-radial, so that the pupillary axis is spared. And then because you know that in these cases, when you're putting the IOL and when the cornea heals, there is going to be some amount of astigmatism.
Yes.
So maybe you can deal with the lens part of it or the cataractus, especially if it's not an intumescent cataract or a white cataract or a total cataract at a later date. So that can also be done. And also when you have a haze over there and the pupil is mid dilated or you cannot see underneath that, one can also put nylon hooks to stretch the pupil and see underneath.
Yeah.
But of course, Dr. Kashyap is is a great surgeon, and
Yes.
he was able to tackle it both anteriorly as well as posteriorly at the same sitting, and then
Yes.
also do a very nice lens aspiration followed by a lens implantation.
Yes. No, because essentially the amblyopia management is what becomes tricky if you don't do a planned surgery in these cases. So even an ideal surgery done as this could be more challenging. And I wanted the opinion of the expert panel. Have you all ever used a lancet knife? This was probably the first of its kind which I saw. So I wanted to hear about Dr. Kashyap's view and your views on that.
So I have not used it, so I don't have any experience. I don't know if Dr. Ramamurthy or Dr. Haldipurkar has used it.
No, was it a fibrosed capsule? What was the need for a lancet knife? Was it a fibrotic capsule which could not be cut through with a bent needle or a cystitome?
So it was a ruptured cataract. The capsule margin was irregular, and only the margins were seen, and we couldn't see any edge of the margin. So it was absolutely blank. Just we could see that there is a cataract. The cortical matter is in the AC, and we couldn't see the capsular margin. and the capsule margin, the capsule was quite floppy. We couldn't manage with the 26 gauge needle or ureterata. I put the ureterata, it will slip off. It will never. I couldn't do it. And even the varnish, I tried to cut it with the varnish. It will never hold it. It will slip off. So,
very well managed. No, I have personally not used a lancet
Yeah.
knife. One query I have is that this vitrectomy part of it was done because you suspected a foreign body.
Intraocular foreign body.
But maybe if you had done a CT scan and an X-ray apart from the ultrasound, you can be sure about, have been more sure whether it's there or not, because maybe that surgery could have been avoided. This was essentially confined to the anterior segment.
No, I have said that in ultrasound we found that there was suspect intraocular foreign body.
Okay. And the other thing is, for the audience, I think if we have access to AIOS-ARC, we need to look at the status of the posterior capsule before we implant the lens in these cases of traumatic cataract. And that was a great surgical video you showed, Dr. Kashyap. I mean, I wanted to bring up these questions more so that we discuss the different aspects of it and so that get more information out over this case. I think before we go on to next case, which is going to be introduced by Dr. Harshu, let us just watch the ENTOD videos. The ENTOD are who have sponsored our ARC webinars. Mr. Sunil? A special word of appreciation to ENTOD for their being very encouraging to science and having sponsored all our ARC webinars. Thank you, ENTOD. We shall now go on to our next speaker. Dr. Harshal, would you introduce him?
Yes, ma'am. So next we have Dr. Ratish Paul, who is a brilliant surgeon from East. He is MD of Suchrut Eye Hospital, Kolkata, and he'll be sharing a case of spontaneous posterior capsule rupture. Dr. Ratish, are you there?
Dr. Ratish?
He had to.
He was there.
He was there.
Actually, right now he's not.
Right now, yeah.
Okay.
Right now he's not there in the panel.
Okay. Yes, he's not there. So we'll get back to him. Keep in mind, Dr. Harshal. So
Yes, ma'am.
we shall now go on to our, just a minute, our next speaker. Next to go is Dr. Swati Agarwal. I can see her there, a young dynamic surgeon who's the assistant professor of Muzaffarnagar Medical College and a prolific cataract surgeon and an oculoplastic surgeon over above. So she is going to show her challenging case. On to you, Dr. Swati.
Thank you so much, ma'am, for those kind words. It's indeed an honor to share the screen with so many eminent personalities. Can you all see the video?
No.
You have to share screen, Swati.
Share screen.
Yes, ma'am, already did, ma'am. I think it's a little slow.
Can you share it again?
No, you click on the video, start to play it, and then Share screen.
Yes, ma'am.
Yeah.
I think now you can
Yeah.
all see the video, right?
Yeah.
We
We
can see
started
your
to
screen
screen
right
share.
now. Yeah. We can't see the
Okay.
video yet.
Can you show you've gone to the right side, screen sharing. Now you click on the video.
Yes, ma'am. Yes, ma'am. Or can you see the video?
No.
Like I'm going to play it now.
Just play.
Screen is still not visible, Dr. Swati.
Swati, put off your camera so that the internet speed goes to your screen sharing.
Sure, sir.
Or Mr. Sai, do you
Yes.
have her video? If you can play her video from your end.
Dr. Swati, can you stop sharing for a minute?
Dr. Swati, you stop sharing your screen, please.
I think her system has hung. She's not even responding.
Yeah. You can just.
Yeah, sir, I'm just trying to open that window. I'll just close this video.
You could
Swati,
close and restart a minute. We have time.
Sure, ma'am.
Can you just close and restart?
Yes, ma'am.
Harshul, you could contact Dr. Paul.
Yeah, I've stopped sharing now.
Yeah, you can
Can
start.
you open my video from your link?
No, but yes. Mr. Sai or Mr. Sunil, do you have a video? Can you play from your end?
No,
so
sir.
She can.
No, sir.
Chitra ma'am, Mr. Sai has no.
No, he's not connected today. Can you connect it and open it, Harshul?
Yes, ma'am. I'll do that. I'll just try to.
Or should we have the next speaker start by the time you get her thing? Or no, you have got
Sure,
it.
ma'am.
Okay.
Sure.
Just 1 minute. No, I think he's connecting you.
Okay.
Dr. Swati, switch off your camera first, then start share. Now do the screen share. Dr.
Harshul is connecting your video, and Swati, once this video opens up, then you should start your talk.
No.
No,
Yes,
yeah, now
I'm
open,
playing.
yes.
I'm playing that, ma'am.
Yeah, Swati, you could start
Yeah.
as the
Dr.
video.
Swati, you can narrate,
Sure.
please.
Yeah, thank you so much. Yeah, this is an interesting case of a subluxated cataract I came across, and I had an opportunity to operate it under assistance of Dr. Rupert Meera. So here you can see that's a supratemporal subluxation, side port entry and the main port entry from with the creatum was made, and rhexis was performed in a very controlled manner with Utrata's faucet. After doing the rhexis, a very careful hydrodissection was done. Care was taken not to inject fluid in the dialysis area at the supratemporal. And because the patient was quite young, so there was more of the cortical, it was a very soft cataract. So the phaco was done. And just in this, you can see there's a little amount of vitreous which is coming from the supratemporal port. So very carefully, I made another port, another side port. And there was also a little loss of followability during phaco. So the rest of the cortical matter was prolapsed into the interior chamber and was emulsified. After this, you can see there was a huge dialysis, and tricot staining was used to stain the vitreous, and vitrectomy was used to cut the vitreous. The bottle height was also reduced in this step, and a CTR was placed to stabilize the capsule. After this, very gently, the lens was implanted into the bag and was gently dialed. Again, some amount of vitreous was there, which was further stained by tricot and vitrectomized. The main port was sealed by the suture 10-0 mono, and the other wounds were hydrated. The lens was, intraocular lens was quite stable, and the patient did well in the postoperative period.
Yes, you can stop sharing. Thanks for this video, and which brings up a lot of discussion, Dr. Swati. It was a soft cataract, so probably you could get away with this, but ideally for the audience to know that whenever you notice a dialysis and you're going to start your phaco, either you support that area with the capsular hook if the area of dialysis is very small, and then you could plan your CTR a little later. But if there is vitreous also presenting in it, you need to definitely have placed your capsular hook. You should place your CTR. You should do a focal vitrectomy
much
before
earlier.
you go on
Yes,
further, so that the area of dialysis would have been better contained. And even in the last step, I wouldn't place a single piece IOL in this case at all. A 3-piece IOL with the haptic further pushing away probably would be the better ways or better alternate ways of approaching.
Yes.
But yeah, you did manage to do your case well, no doubt. But these were my thoughts. Anything to add, Dr. Namrata?
Definitely, ma'am.
I think I agree with you, Chitra, completely. And hooks and this thing would have been a better option. But of course, the case was soft, the cataract was soft, and so they could get it. Swati could very well manage it.
Yes. Thank you, Dr. Swati, and thanks, Harshul.
So after this also, ma'am, we had a lot. Yeah.
Yeah. Yes, Dr. Swati?
Okay. I was saying after this case, we had a very nice grand round discussion with our residents as well as our professors as to what could have been well managed. This case came to us during these COVID times, and being a medical college, all the faculties were not present at that time. So I had a chance to get such a challenging case. So yes, those were definitely my learning points, which you highlighted so nicely, ma'am.
Yeah. Thank you. Dr. Harshul, shall we go on to
yes,
our next case?
Ma'am, if I can just add on it.
Yes, Dr. Lina. Yes.
Dr. Swati, kindly have a follow-up of that case, because we are not used a ring to stabilize the subluxation. So there are possible chances of asymmetrical contraction of the bag.
No, she has placed a CTR later.
Oh, she did.
She has placed it, yeah.
The patient has been followed till 3 months and is 6/9 parts unaided.
Yeah. Okay. Dr. Harshul?
Yes, ma'am. So let's move on to our next speaker. And our next speaker is Dr. Umang Mathur, who is a prolific cataract surgeon. He is the executive director of Shroff Charity Eye Hospital, New Delhi, and he leads his hospital in various forefronts. Dr. Umang Mathur?
Yeah, thank you so much. So I'll be presenting this case of a nanophthalmic eye. And as we know, nanophthalmus is a short eye with a short axial length and a shallow anterior chamber, often with glaucoma, and has the problem of uveal effusions because of thickened sclera and thickened choroid. So this patient, and very often they have steep corneas. These are basically eyes that have stopped growing. And so like a child's eye, steep cornea with a short axial length of 16 millimeter anterior chamber depth of 2.2 and 2.4. And the other big problem is what IUL to implant, because different formulae can give you these bizarre results. And I have found it to be closest to the Hofer Q formula in these eyes. So it's best to go closer to the highest that you get with all these. Now, the big problem with these cases is a problem of uveal effusion. And sometimes eyes are lost because of that. And so, and it's best to be done under general anesthesia because you don't want pressures because of your peribulbar. Here we are making lamellar anterior sclerotomies to decrease the uveal. If there's a uveal effusion, we want some leakage to happen. So my retina colleague helped in making these between the recti. So this is basically lamellar sclerotomy about 5 millimeters from the limbus. This is prophylactic, just in case we require. I've had a situation where we lost an eye. We also were prepared in case there's a need. We'll do a pars plana vitrectomy to decompress. So with Helon, because there's very little space in the chamber, we went with a stop and chop to debulk the nucleus first. Fortunately, till the phacoemulsification, the eye behaved all right, and fairly hard cataract. The nucleus, surprisingly, in all these cases is pretty large. And I am almost of the opinion that whenever you see a nanophthalmic eye, it's best to remove the cataract, even if there's no cataract. Do a clear lens extraction, even if the child comes at, say, 15 age or something. It's best to remove it because it's easier to remove the cataract as a clear lens. But these cases can be pretty challenging. So the phacoemulsification went fairly well. The nucleus, although the space is very limited, you have to be careful. And up till even IA, the eye behaved reasonably okay, but you can see at this point now, there's a lot of crowding at the incisions. And while we were getting the IUL ready, you can see now the eye is becoming very hard. The iris is coming out of most of the ports, and then we, through a pars plana, debulked a little. And there was some discussion on the cartridge and how to put these thick lenses. So I used a B cartridge on a customized lens. So putting this thick lens was not very easy. There's very little space. And again, but I think the vitrectomy helped a little to debulk. The retina colleagues are also, they find this very challenging because the pars plana is also not very well defined. So with that, we put the lens in and went into the bag. Maybe I'll just end here.
Thank you very much, Dr. Umang. That was a very challenging case, which you brought out beautifully with all the relevant things which need to be discussed here. So we'll have you on here now. I agree that the most important thing besides all that you said is also getting a rexus if the anterior chamber is shallow. This was 2.2, so you could do it. Otherwise, sometimes it's better to do a smaller rexus and then go on to making a larger one. The other thing is, there are some of these randomized control trials which have tell us today that a sclerostomy to be done prophylactically is not mandated because the visual outcomes are comparable if you are able to decongest the eye and vitreous and plant surgery.
Actually, we as doctors very often get swayed by what's happened in the case before. I think just before I had this case, I had a case which I lost. So I didn't want to take any chance. And in this particular case, we preferred to do this prophylactically, but I'm aware of the studies which say that it doesn't make too much of a difference. So I think these are just very difficult cases. So I didn't want to take a chance in this one, but I've done a few without it as well. So you may be right. And the studies say that it doesn't make too much of a difference.
Yeah. And I seem to be more convinced than Hofferskew that Barrett's and maybe Hill RBF are probably even better formulas for these small eyes. And of course, customized IOL was well discussed, the challenge which is there about the incision size and the right use of cartridge. And the last thing is the refractive surprise, which you can see in this eye. One very important point which you brought up is doing a pars plana vitrectomy, which is sometimes needed, as it happened in your case. The location of the pars plana is not well defined in these eyes. Dr. Suhas, Dr. Ramurthy, Dr. Namrata, I want your thoughts on this case.
I think Umang, again, a very difficult case, and I would completely agree with you that if you have such an eye with a cataract or very early cataract, I mean, you should immediately go and do it, because later on it can become a problem. Likewise, even for, colobomatous eyes which have cataract, because you think it is not hard, but it actually very hard. And these are the patients who we keep on postponing for some time, or our colleagues postpone, okay, wait, but I think they are dealt earlier rather than later. And regarding those sclerostomies, I think I would agree with you completely. Even I have had a case an eye which was lost. So I also, am very cautious about this. I think very nicely. Otherwise, Umang explained everything very well, and difficult case and a challenging case to do. Can be only done by surgeons like Umang who, deal with such tough cases.
Very nicely done, Umang. I mean, very impressive. Just a couple of thoughts. One is that this posterior sclerostomy, as was already mentioned, was more a hangover from the era of ECC days when you had larger incisions. Now with control 2.2, 2.4 millimeter incision maybe is not necessary. And as it happened in your case, in spite of the sclerostomy, the eyeball became tense and you had to do a pars plana vitrectomy. So I think by and large, of course, these are always challenging cases. Most surgeons don't do this. And even when it was recommended, it used to be done at least a week before the primary surgery. And then only it used to be more effective. If it's done at the same sitting, it was said that it's not of much value. And coming to the intraocular lens as such, the earlier case where we had a 18 diopter cylinder, obviously it's a cylindrical power, it had to be calculated. But in these cases of extreme hyperopia, as you also mentioned, I believe none of these formula, including the Barrett, work significantly. And I have always, in these cases, I have gone ahead and implanted a primary lens of plus 40 diopters, aspheric single piece, and then calculated the residual power and just multiplied it by 1.5 and gone ahead and implanted where you don't have to use any formula, and went ahead and implanted a piggyback lens. And because these are naturally thick lenses that you are explanting, they do give you space for implanting two lenses. And that gives you much better refractive accuracy than any of these formula. But as you showed in your own case, each formula was showing a different IOL power, and it's a toss-up as to which one to choose.
Yeah, I've generally found it to be closest to the highest in these cases. So if you have 37, 45, 55, it'll be somewhere close to 50. So it's generally closest to the highest.
It might work sometimes, but sometimes it doesn't. In one of my cases, the SRKT showed the best result retrospectively compared to say the Barrett or the Hill RBF or any other formula. So and they were all over the place, right from 40 to 56. So I believe doing it in two stages sometimes gives you better accuracy.
Is Dr. Suhas connected?
Yeah.
Yeah. Do you have anything to add, Dr. Suhas?
Well, first of all, compliments to Mathur. In that case, he tried to highlight practically every point that really concerns us. The only point I would like to add is when Dr. Ramurthy talked about piggyback. Well, yes, we have done piggyback with different lenses. Earlier, we used to do with a regular lens, just making sure that they were of different materials. But today I realize using those Sulcoflex lenses probably work best because they're always convex on convex or concave lenses. And that's the reason they sit properly on top of the primary lens that you have put. And obviously the primary lens that we put is maximum diopter. So I think if the calculation comes to around 50 plus, then we would definitely go for the maximum available from a company. And most of those are around 35 to 40. But there are instances where when people have done SICS, controlled SICS in such nanophthalmic eyes and use 60-65 diopter of a lens one stage, because there the issue was using a cartridge didn't arise, could easily put that lens through and they got first shot good results. But for us, when we do phaco with a small incision, I think putting maximum and using secondary IOL with after the refraction is stable is probably the best way, but to go for a Sulcoflex lenses.
Right.
Thank you.
About lenses, the other negative aspect is the amount of spherical aberration they induce. With the 60 diopter, 56 diopter, huge amount of sphere. And what the manufacturers do, they don't talk to you about it, is that they reduce the optic size to 4.5 millimeter. So when you put a primary lens, an aspheric lens, and the Sulcoflex lens is actually has zero asphericity. So basically the quality of vision is also better.
Sir, what is your recommendation on the pars plana? How posterior to the limbus in such cases do you recommend?
Yeah, so that's a good question. In fact, one particular case, I had my retina colleague with me, and we had a similar problem. And usually I find the problem arises just before putting the IUL. The case is generally okay till the phacoemulsification, and the effusion suddenly happens. Probably that's when the space comes and you lose some chamber. And I asked them to make a pars plana incision, and the whole retina detached. So you're not very clear as to where the pars plana is in these cases. So it's challenging. But yeah, Dr. Kashyap.
Any recommendations?
Well,
2.5.
Switch off the light of the microscope. Use the endolight. It will tell you where is the shadow, and that shadow is starting of the ciliary body area, and you can understand where is the pars plana.
Good. Thanks, Dr. Umang, for a wonderful video and for all the inputs. Is Dr. Gopal Raju there? I didn't see him at all.
He has written that there are some connectivity issues. So in case he's not able to connect, his video should be played.
Oh, okay.
In the chat,
Question, please.
Yes.
Has any of the esteemed panel talked about the IOL in especially the nanophthalmos people cutting the optics and putting just the optics? I heard in one of the papers somebody reading. Any experience on this?
I think Kumar doctor has shown it, a case like this where the haptics were cut and the lens was put in a very small eye, but I don't think any of us, at least I don't have any
But
experience.
generally you find the nucleus is big.
Yeah. The nucleus is not small.
The nucleus is not small. In fact, that is one of the features of nanophthalmos. The lens to the eye volume, the ratio becomes different. So you don't really have a problem of putting the lens. Accommodation of the lens in the bag is not a challenge. So you don't really need to put a very small IUL.
Harshal, I don't think Dr. Gopal Raju's video has a voice overlay in it. So
you want me to play that video, ma'am?
Yeah, no, but it'll be quiet, those 4 minutes. It doesn't have a voice overlay. Can you just check it on the side? If it has, then we can play it. I don't remember. We go on to our, you go on to introduce Dr. Satyajit Sinha.
Yes,
and while he talks, maybe you could check.
So our next speaker is Dr. Satyajit Sinha, who is Managing Director and Chairperson of ABI Hospital, Patna, who is also a member ARC East Zone, and is a wonderful surgeon, and he's going to present his case of uveitic cataract. Dr. Satyajit?
Dr. Gopal had 2 good videos, Harshul,
I'll
in
be
case you
sharing
could
those,
play.
ma'am. Yes. Yeah. Afterwards, ma'am. Yeah. Dr. Satyajit?
Yes. You should unmute yourself, Dr. Satyajit.
Yeah. I'd like to thank the Academic and Research Committee, Dr. Chitra Ramamurthy, Chairman, for giving me this opportunity. I'll be talking on post-uveitic cataract tips and tricks. We had a patient, 38-year-old female with history of treatment for CS cervix. Old reports revealed the being positive for COX in 2017. On 16 September, she came to us with August. She came to us with vision in right eye, counting finger, and left eye also counting finger. We diagnosed her with dense PSC both eyes. She had a festooned pupil and she had a uveitic macular edema in the right eye, which was revealed on seeing the OCT. Her applanation tonometry was 12-12 in both eyes. This is the picture of the macular edema which was there. In primary management, we had given her injection Tricot intravitreally in the right eye, and then phacoemulsification was planned after 15 days. OCT showed reduction in macular edema on 1st of October, and then systemic steroids were also started preoperatively to lessen any inflammatory reaction postoperatively. She underwent phaco on 2nd of October, and this is the surgery. So this was the festooned pupil which was there initially. We made a paracentesis and then we released the synechia which was there. We gave a pupil dilator also, but the pupil didn't dilate much. So then we went ahead and used iris hooks. A pupil expander can also be used like BHEX, which may probably give a less post-operative inflammatory reaction. But in this case, we were using these iris hooks. The visibility in these kind of cataracts, especially in the anterior capsule, the visibility is a little compromised. But slowly the rexis was completed. It may be a good idea to use blue also. In between, the iris may be floppy in such cases, and there may be iris prolapse also. So it may be a good idea to keep hydrating the cornea so that the iris prolapse is as less as possible. It is very important that you do a good hydrodissection and then rotate the nucleus to make sure it is rotating well. And then these kind of cataracts are generally more cortical, so it comes out easily. And then you do irrigation and aspiration. Once that is there, then the red reflex becomes a little better. It is very important that all the cortical matter has to be cleaned properly to reduce the post-operative inflammation. All the cortex should be removed carefully by going behind the iris also. And then an acrylic hydrophobic IUL was inserted. In this case, through that 2.2 millimeter incision. It is very important that all the viscoelastic which is there should also be cleaned too, so that the post-operative inflammation is as less as possible. We should also go behind the IUL and remove all the viscoelastic. Then all the iris hooks are removed. The wounds are hydrated. This is the first day post-op picture. This was after 1 week. This was after 15 days. And at the end of 1 month, the eye looked like this. And from counting finger, this was the post-operative picture of the macula. And the patient came to us with counting finger vision, and on 30th then she had 618 vision. Topical steroids were prescribed in tapering doses along with continuing systemic steroids in reducing doses. Thank you so much for your patient hearing.
Thank you, Dr. Satyajit. That was a wonderful video, the way you managed right from the pre-operative to intra-op to post-op. Actually, I was breaking my head where to question you at all in this. There's one thing which we all noticed, that he never tried stretching the pupil, and stretching the pupil, had he done it, would have caused the iris to become a little floppy, and has used the iris hooks very appropriately. The only thing, if you really want to get too critical, is that you could have suggested that he could have used one subincisional iris hook, which would actually, if sometimes the iris gets very taut between the two iris hooks. So when a subincisional hook is placed, then there is no stretch on the iris when the phaco probe goes in and out. Maybe that could be the only thing which would have said. But the wonderful tip he gave was the hydration of wound, which is something I'm going to take back and do. He kept hydrating the wound as he was doing the procedure, which that though you clearly know that it's very important to do that for iris prolapse, but somehow I never did that. So good learning video, wonderful.
Thank you so
Open
much.
to the expert audience and Harshul for any thoughts on this.
So just for my own, sorry, Harshul, you were saying something?
No, ma'am. No, ma'am. I was trying some name. Sorry.
I just wanted to know, and I'm sure others know about it. What is the time gap which you normally would keep, after a macular edema is there, and when you think that, okay, the surgery can be done for cataract? Dr. Kashyap is here. Yeah, maybe he can tell us all.
Generally, we claim 3 months, minimum 3 months right now. That is the time when we tell stabilization of blood aqueous barrier happens. Is that so?
I could see the
yes.
take the OCT very properly. The OCT, it was very clear. It means the media was not very hazy. Probably we could repeat the OCT.
And then, yeah, that makes sense. Anything else to be added, Dr. Ramurthy, Dr. Suhas?
I have one suggestion,
Yes.
ma'am. How common do we, in such uveitic cataracts, how common do we add intravitreal triamcinolone or PST triamcinolone intraoperatively?
Intraoperatively.
Yes.
Basically, there are 3 options. Either you can give subtenons or intravitreal triamcinolone, or of course intravitreal Ozidrex. Ozidrex, if the patient can afford, is the best to give, simply because it's a very titrated amount of 7 micrograms per day, and it lasts almost for 100 days. And potential for raise of intraocular pressure is also quite low. Obviously, cost is a factor, and sometimes if patients can't afford it, you have to do this. And but only thing I noticed, Satyajit, beautifully managed, very well done, good tips. But when you have already given a IVTA, why put this patient on systemic steroids also, which you continued? And did you have a systemic workup of these patients before taking her up for surgery?
Absolutely, all the sugar parameters and the blood pressure and everything, and physician clearance was taken before all systemic steroids were given. And systemic steroids are given mostly to be sure that post-operative inflammation is as less as possible.
The reason I brought this up is, you also mentioned the history of Cox tuberculosis, which was 3 years back. And, sometimes we guys are just so focused on the cataract, we forget about the other reasons. And you put the patient on systemic steroids, and if it's a tuberculous uveitis, you could have a bad flare-up. So my suggestion is that, when you get cases like this, even though you might be the operating surgeon, it's a good idea. We always get a opinion of our VR colleagues or uveitis
So
colleagues.
he would have had Dr. Pooja opinion on it. Dr. Pooja Sinha would have given her thought.
It's just a message for the others too. I mean, you might be capable of doing the cataract surgery part of it, but it's important that you get the patients worked up properly, so that you don't end up with problems which you didn't anticipate.
Yes, sir. Yes,
sir. Would you start the patient on atropine eye drops post-op? Or
not on atropine, because that will dilate and fix the pupil, but definitely maybe on homide or something till the inflammation comes
or
out.
maybe on table, if you could put a drop of atropine, depending on how much handling has been there on table.
Yes. I think there's anything else to discuss. Shall we go on to our next? Dr. Suhas? Yes, doctor.
Satyajit.
Yes, sir.
Your patient didn't improve beyond 618. Could you investigate and find out why he never went beyond 618?
We'll do that,
yes.
sir.
Yes.
No, because like you had, you had intravitreal, and then after that you waited for 15 days, and then you operated. The post-op, did your systemic steroids or local steroids continue for little longer than normal? In what way was your post-op different from a routine case?
We were giving systemic steroids, sir. We don't give systemic steroids to everybody. Otherwise, the post-operative regime which we use for all the patients was the same. Like in reducing doses, we were giving topical steroids, prednisolone eye drops.
Till how long?
Even
would you keep it good?
Kids, I think something like a Nepafenac or Nevernac would be a better idea, so that the macular edema.
That is a standard we use. Nepafenac for all the patients post-cataract surgery.
Oh, I think it's a very important point. Most patients don't tolerate systemic steroids over a long period of time. It's not necessary also. Most often with a PST or a Ozidrex that takes care of postoperative inflammation, you just continue steroid drops for about 3 months. I mean, start off with 8 times a day and then very slowly taper it down and maybe use them for a couple of times. And of course, non-steroidal anti-inflammatory drops, as was mentioned, is also important, along with lubricants. So I think most often, unless you find a recalcitrant problem, in which case a UVI expert has to handle it, I think it's for us, topical drops would be good enough, especially when you've already given a PST also.
Yes, sir.
Dr. Suhas, you have anything to add?
No.
I have.
Yes, Dr. Raj.
I want suggestions from both Ramurthy sir and Suhas sir. What is the preferred size of capsular excess in such cases? Do you tell? Because larger the excess, more often there will be optic captures. Smaller the excess, most often goes for phimosis.
Yes.
So what do you
Probably a standard 5.5 should be enough.
More, I think, on the larger side than on the smaller side.
Small side.
You don't
This
want
is one situation where I might recommend polishing of the edge of the anterior capsule more, because reduces the chance of anterior phimosis. But very often your size of the excess is limited by the pupillary dilatation. Of course, you use dilating devices like what Satyajit showed, then that's not a constraint. But a 5.5 millimeters so that you get a good overlap, but as big a excess as possible would be a good idea.
For the learner's sake, it is hydrophobic acrylic, which is the best in such cases.
Yes. Right.
These are cases where polishing would be done always.
Yes. So thank you. We shall now go on to our next speaker. A good video, Satyajit. Our next speaker is Dr. Rajesh from Guntur, who's the director of Sudarshini Eye Hospital, has a dynamic presence in Andhra State Ophthalmic Society, a very capable and versatile surgeon, and he's going to display his teaching pearl. Dr. Rajesh?
Yeah. Can you see my video?
No, you need to start sharing your screen.
Yes, sorry.
Yeah, we can see now.
Yeah. Basically, I got a thank you very much, Dr. Chitra Ramurthy, for giving me this opportunity to share the webinar with the stalwarts of the Indian ophthalmology. I have a short video. Basically, this is about dealing with a hard cataracts, and I've slightly dramatized it. You can see the video. There is a voice overlay also for that.
Is the
video
playing?
not playing? Video is not playing.
I'm sorry.
Doctor, can you stop here?
You have to share your video.
Yeah.
Just stop share.
No, yeah, just play it. Yeah.
Play it.
You need to, doctor, you need to open.
Can you see that now? Can you see that now?
No.
Can you stop share for a minute?
Touch the video screen.
But start with the video screen, not the photo screen. Just stop and then share.
Could you stop sharing?
Yes.
And then open that video and then share?
From the video.
Actually, ideally, all of y'all should have done this before the webinar started. Yes.
Dr. Rajesh, you need to first open the video.
Something we all face in our day-to-day surgery.
Dr. Rajesh, only the voice is coming.
Very difficult.
Video is not playing. You have to click play.
Yes,
Yes.
All right.
Good. Yes. Go back to the beginning.
Is something.
Yes. Thank you.
Sorry. Hard cataract is something we all face in our day-to-day surgery. It is always very difficult trying to manage these hard cataracts. One of the area that we find most difficult is when we are trying to break the nucleus into number of pieces. It is sometimes very difficult to break the posterior plate of the nucleus, as it may be very hard or leathery. While trying to break the nucleus into small pieces, we may cause a break in the posterior capsule or can also cause zonular dialysis. Let us look into another case of a hard cataract. We can see that we have to do many maneuvers to break the cataract successfully without damaging the posterior capsule. It is always very dangerous to go deep into the nucleus, as we risk having a rent in the posterior capsule. I always thought it will be nice to have access to the posterior plate directly to the phaco tip. Since we cannot approach the posterior plate with the phaco tip, I thought, why not flip the nucleus? That is when I tried the somersault in a half piece of the nucleus of a hard cataract. I was successful in turning the nucleus and so could get access to the posterior plate of the nucleus directly to the phaco tip at the pupillary plane. Why not try this in other cases? I tried this in a grade 1 cataract. It worked well. I didn't even need a second instrument. What I have done here is flipping the nucleus 180 degrees so that the posterior plate comes to lie in the pupillary plane. I tried in another slightly hard grade 2 to 3 cataract. Here also, I could do it successfully. I had no difficulty in doing the phaco somersault and have noticed that I have accidentally mastered another technique of doing phaco emulsification without a second instrument. Let us see how it is done again. Catching hold of the edge of the nucleus at the equator, the nucleus is maneuvered in the pupillary plane for easy emulsification. The advantage of this new technique that I have developed is that it can be done in all types of cataracts. There is less phaco time, very less phaco energy is used, and it's a useful technique to access the posterior plate easily, thereby minimizing the risk of posterior capsular breaks when we go close to it. Phaco somersault. Thank you.
Thank you, Dr. Rajesh, for showing a wonderful video. Just for the sake of discussion, I wanted to bring some points forward. I think in a soft cataract, you can just go like in these modern machines, we can go into the flip is probably what is somersaulting and you are able to do it. But in a hard cataract, I think you need to, you can't bring out the whole nucleus into the, unless you make a very large rhexis. I think you need to make a heminucleus and then probably do a flip, no?
Yeah, in harder cataracts, it's basically the half part of the nucleus.
Yes.
That is
That
just,
only.
when you want to break that the half part, then it is easy to flip it and then use the somersault.
Yeah, but again, I think because of the higher phaco energy, I don't think it will be that protective for the cornea. Probably the somersaulting is better for soft cataracts, no?
No, all the surgery is happening in the pupillary plane only and below the pupillary plane only. We are not going into the anterior chamber. So I have noticed that I have checked the effective phaco time and the phaco energy. It's definitely less in these cases when I'm using this technique than the routine chopping or the vertical chop or other techniques.
Expert opinion needed here.
I would
Dr.
just
Namrata Ramurthy.
point, ma'am.
I think
Yes.
we all have been probably doing it inadvertently, but Dr. Rajesh has very aptly named
Aptly.
it as a somersault phaco. And flip, yes, in soft we were doing it, and that was also like a somersault. In hard cataract also it makes sense because the whole curvature of the lens is changed. You know, it's concavity like that, and then it becomes a lot easier to phaco it. Then to go along the concavity, and then sometimes to struggle it to reach at a deeper plane. But I think it's another way of putting it, but it summarizes the whole concept very nicely.
Yes, Saurabh, you wanted to say something?
Yeah, ma'am. I was just making a point for sir, or rather asking him that, in his experienced hands, maybe the power, time, and everything was coming up less. But there are a lot of youngsters watching this, so bringing a hard cataract way above, because it clearly looked like it's an anterior chamber phaco surgery.
Phaco, yeah.
So it's
So
not.
I think within the contains of that crater, if it is being done, which was shown, and it's not that whole nucleus which is somersaulting. It is only when it has been debulked significantly that the whole thing is somersaulting. So I think that concept was brought out very well.
Yeah.
I would like to somewhat differ in the sense that, I think it's a great technique for soft cataracts. You practically phaco aspirate. You hardly use any energy and do it in the anterior chamber. And maybe in subluxated cataracts, again, you would like to bring the lens out of the capsular bag and do it. But in the hard cataracts, I do not think this is the right technique, simply because I don't believe there's anything called iris plane phacoemulsification. It's just in your mind. Once it's out of the bag, it's in the anterior chamber. And when you are using, it's a hard cap. You rightly said that you need access to the posterior plate. And the access to the posterior plate has to happen because of a phaco chop or because of a stop and chop, where you create a deep enough groove and split it into two. And maybe make small. That's why you say the harder the cataract, the more bits you do, so that the amount of energy that you make 8 bits, 10 bits, maybe as medium grade cataract, you just may chop it into 4 bits. So when you bring this entire cataract into the anterior chamber, I think as Namrata pointed out, some of us end up doing it once in a while. You have a rexus runoff, it comes into the anterior chamber, but I'm not at all happy doing it. And there is a significant amount of phaco energy that's consumed, as Saurabh pointed out. I mean, it could be quite, however much the dispersive viscoelastic you might fill, it might be quite deleterious to the corneal endothelium. So the idea is to stay within the confines of the bag, split the hard cataracts into as small pieces as possible, break the backbone of the nucleus, and then each and every chip, if you can emulsify in the bag, it's possible. But sometimes you have to bring it into the anterior chamber and keep your probe as inclined as possible towards the posterior pole, and then emulsify it, which is just not possible if you bring the entire nucleus into the anterior chamber. And I was noticing even in your videos, it's fairly close to the corneal endothelium. So maybe I would have reservations about doing this technique.
Dr. Suhas?
Well, just another way of skinning a cat. And, he just found it and he's kind of mastered it. It's easy in his hand. But for the general public, who are struggling to really get into basic techniques, I think it probably is not a technique, at least I would put my, bet on. There's so many others. But anyway, he has got them, he has mastered it, he's doing it. Thank you.
Well, if it's a hemi-nucleus or if it's a hemi-section, sometimes even quadrants, I don't see any harm in doing it at all.
Yeah. No, Rajesh, that was a wonderful skill,
Yeah.
the way with which you dealt with it. But these discussions were necessary for the
So it's more
general
of-
audience to know.
It's
Yes.
more a point counterpoint. It's not that, I mean,
Yeah.
if it works in your
Yeah.
hands, there's no harm in your
Nothing.
doing it. But
Yeah.
I mean, I would be a
Yeah.
little wary of doing this.
I'm trying to check the corneal endothelium in all these cases with the routine chopping, vertical chops, and with the phacosomal salt. I'll come out later with the
Sure.
endothelium.
Yeah.
Yes.
Yeah.
May-
He would have less heart in mouth surgeries if all of us could do this and get done with those cases.
And maybe Dr. Rajesh you should also try to define in which scenarios this may be useful, rather than telling it is the best
universal
rather than telling that way, like Ram Murthy sir said, when there is a rexus break, when we don't want a lot of manipulation within the back, so you can define. So that will be
when
great.
there is a rexus break, even when there's a jigsaw puzzle kind of a thing, and then it just doesn't, it just refuses to.
Yeah.
That thing is just not. There's no space at all in the capsule. Even then, I thought it was useful.
Yeah, I usually anyhow for a hard cataract we go for a slightly bigger rexis and I make sure that it's a bigger rexis, and definitely, of course, I avoid it in all pseudo exfoliations.
Anyway, thanks a lot. It was nice hearing you. A nice video. Thank you very much. Harshul, would you introduce our next?
Yes, ma'am. Yes, ma'am.
And
So,
Harshul, you would have to later at the end of it play
Yes.
Dr. Gopal's video.
Yes, ma'am.
Yeah.
So it's my pleasure to invite Dr. Sajjad Fazili, who is a leading surgeon from Jammu and Kashmir, who is the director of Fazili Eye Care Center, Kashmir, who is also president of Kashmir Ophthalmic Society. We all know he is a prolific surgeon, and he always presents challenging cases in all the conferences all over India. It's great to have you, Dr. Fazili. Can you start your screen sharing? Yeah. We can't hear you, Dr. Fazili.
Dr. Fazili, you need to stop and then enable the show sound. Can you just stop? Dr. Sajjad? Just stop share. Dr. Sajjad?
Yeah. Yeah.
Now enable sound before you share, sir.
That was a good video of yours, Dr. Fazili. We need to see it.
Yeah. Share. I'm trying to share. Can you hear me now?
No, we can hear you.
now. Yes.
So just click on the share screen once.
Yeah.
And on the bottom there is
No, you have to have your video open. The video which you're going to play. Yeah.
Yeah.
Yes.
We can see it now.
You can
Yeah,
hear
we can see it now. Yes, you can
yes,
play it.
Yes.
Okay. So whenever we're talking about pseudo exfoliation, you can hear
No, we can hear you, but the video is yet to. Yeah, it's playing.
Perfect.
Yes, go ahead.
Perfect.
Go ahead. Perfect.
So talking about pseudo exfoliation means that you have to raise your antenna for potential problems during surgery. Despite the surgeon's best efforts, weak zonules may not be noticed until after the surgery has begun. You see here, I'm showing you a case with pseudo exfoliation. One of the problems is not there. It's not a small pupil, but as the air bubble goes in, watch the lens. Every time you go in and out, watch the lens and watch whether there are any unusual changes in the movement of the lens. When you don't have radial tension from intact zonules to pull against, the rexis can always be an issue. The start has to be visualized, the back has to be seen whether there is any
problem there. Here it's proceeding nicely, but it can always behave very strangely or start shooting out. Here, I'm keeping it almost parallel to the pupillary margin. I generally put capsular hooks if there's an issue even before. Again, hydro dissection, wash the bag, watch its movements. And once you're trying to you're trying to rotate it, you can see that this bag is not very, very stable. So you have to do this gently. You cannot be very aggressive. You can see I've already noticed that you bring down the bottle height, bring down the irrigation, and you go. And chopping is perhaps the best technique. Puts least amount of pressure on the zonules. Now initiated a crack, reasonably good. I don't want to rotate this bag too much. I'm just trying to hold this here, and then suddenly I see that the zonules on this side are suspect, and now I'm thinking that all zonules are suspect. So what I'm going to do is put capsular hooks. And capsular hooks, by virtue of their shape and size, support the bag better than the iris hooks, since they support the equator, and the blunt tips, the tips are blunted so that they don't injure the bag. The capsule does not get torn. But I have worked previously with iris hooks also, but iris hooks would always be needed to be combined with capsular tension rings, and they would never be able to support the equator. So now what we are doing is trying to bring all the supports, trying to err on the more cautious side. I could have started on one side. The capsular tension ring is going in. Now this is very important that we know when to implant this. So it can be delayed, but when postponed, when positioned in the capsular bag, the ring exerts an outward force, and that redistributes the tension within the bag. And then you have to bring down the bottle height further, work on lower parameters, literally make it slow motion. Because whatever zonules are left, where there is, we know now there's a weakness, whatever zonules are left, we want this to proceed slowly. And we want to do it at much lower parameters so that we do not actually still manage to, I've seen many a times a PC rent happening even when you're taking the last piece, because in spite of the CTR, there may be an issue. And then you do a cortical cleanup. It's obviously more difficult when you have implanted a CTR ring first. And then you implant a lens which is slowly unfolding and place it in the bag. Normally, at this point, I would first normally remove all the hooks and then remove the viscoelastic. Here I am removing some amount of viscoelastic, and then I am stromal hydrating the main port so that there's some viscoelastic left. Not all of it is cleaned up, and I remove the again, that is because when I go in with the fluid, there may be an issue and that I'm gonna lose the bag. At the end, I wash with irrigation only and hydrate all the side ports with this idea that even if some amount of viscoelastic, in spite of a pseudo exfoliation and the possibility of the IOP spiking, I might still get away with not having a bag which has fallen into the vitreous with aggressive irrigation. Thank you all for your kind attention.
Thank you, Dr.
Thank
Fazli.
you.
That was a extremely wonderful teaching video. With the number of capsular hooks you have placed and giving the anterior-posterior support, I actually wonder whether you could have even placed a CTR right at the end so that there is great ease in removing the cortex too, because that was a massive support you had provided all around. So.
Yeah, it's actually very surprising how pseudoexfoliation can actually behave. So if you have this patient was a one-eyed patient, he had already lost the left eye to a less careful surgery. And then to my mind, placing a CTR should be as early as necessary, but as late as possible. So if you are trying to err on the safer side, then you would want to implant it earlier, especially if you're using capsular hooks and not iris hooks, which are usually available to most surgeons. But to my mind, another important thing is that if you are using, I agree with you, if you're using them late, every step, if you're confident, every step becomes easier, especially the cortical cleanup. Because cortical cleanup can get a little slow, a little dragged because of the capsular tension ring. I agree with that.
And again, in your particular case, placing a single piece lens was fine because till the end, the area of dialysis was not very obvious, but probably otherwise a 3-piece IOL could have been placed as a alternative for giving that extra support.
Yeah, I understand. You mean a segment?
Not a segment, just
Yeah.
a 3-piece IOL instead of a single piece is just a thought.
Yeah,
Could
yeah.
have been done instead.
A single piece IOL in the bag?
No, a single piece IOL is what you have placed in the bag.
No, sorry, a multi-piece in the bag?
In the bag, yeah.
Okay.
Could have been a thought. I want the opinion of the expert panel or anything more to discuss. He has very well discussed his case.
Yeah, I would like to come in, Chitra.
Yes.
Yeah, doctor has shown a beautiful case. It's a difficult case, and he has done a wonderful job. But I just wonder, since he's from Kashmir, in his ethnic population, what are the severities of this pseudo exfoliation at a later date? Because when we do pseudo exfoliation, and if it's of a advanced nature, and at the end of the surgery, you find everything to be well settled. Now, these are the people who come back after 9 or 10 years with subluxation or sometimes a severe dislocation of a lens. So I just wanted him to share what's his experience with such advanced pseudo exfoliations coming later on with some complications. Dr. Sajid.
Yeah, I don't know. I come from a place where pseudo exfoliation is very rampant.
Okay.
And to be very honest, the zonular laxity in pseudo exfoliation cases is one reason why many colleagues are referring cases to me. I have had a large series of these cases, and astonishingly, I have not seen more than around 5 or 6 of nucleus drops or what we say a gross subluxation of the bag. Most probably because if you are very careful and aware, 2-3 things definitely happen after a cataract is removed in pseudo exfoliation. One is that the amount of pseudo exfoliation actually seems to reduce. Number 2 is that if there is no capsular contraction, active capsular contraction taking place, and if you are doing regular releasing YAG laser capsulotomies in the anterior capsule while you are following up, generally speaking, the capsular contraction is the reason why these cases might land up in dislocation, subluxation, eccentricity of the lens. But overall, cases well done, I have not experienced, it's a very insignificant ratio I'm talking about. I've experienced 5. And that is in around 20 years of doing subluxation. But considering it as a very bad case scenario and taking extra, like Dr. Chitra told me that you were using so many hooks. It was because I was erring on the other side. I was erring on the more cautious side. So I'm trying to save as many as zonules that are left. We know that pseudo exfoliation is also a progressive disease, but strangely, the zonular weakness seems to slow down a little bit. I've not actually encountered many. One of the reasons might be that a patient finally goes to some other doctor, finally for the follow-up, because they thought that they had gone to one doctor and he did not do a good job. But they're usually happy because after surgery, because they have been referred and they've had a good result, and that should make them happy.
Congratulations, Sajad. Devan. I think it's a beautiful surgery, and your 20 years of experience of doing these cases stood out in the sense that it was so nicely handled, and even that the elegant chopping. And I completely agree with the timing of your introduction of endocapsular ring, because though the capsular hooks give you anterior posterior support, you need circumferential support of the limited zonules that are available. And this cataract hardly had any cortex, so it was not really a challenge, and you handled it beautifully. But just to echo what the point my friend was trying to make, I think, it was an extremely loose bag, and Suhas was trying to make extremely loose bag, and that's the reason you had to put 5 or 6 capsular hooks. And as you also mentioned, it's a progressive zonulopathy. Though your experience has not shown you that, most often these cases tend to subluxate the entire bag lens complex over time. And in these cases, putting in a CTS or a Sionis ring, especially nowadays, the trend is to put 2 CTS in diametrically opposite to each other, so that you sort of tether it to the sclera, and even in the future with the lens in the bag, there's no tendency for subluxation. The other point that could be made was the 3-piece lens in the bag was talked about, but the greater tendency now is to put the lens, a 3-piece lens in the sulcus and create an optic capture in the bag. And that is again something which is supposed to give extreme stability to the capsular bag. I think it's tremendous surgery. I don't know whether I could have done the way you did it, but 2 things I would have differently is that I would have put in a CTS, especially considering the amount of support it needed for you to continue with the surgery, to tether the capsular bag to the sclera, and secondly, maybe use the 3-piece lens and in the sulcus with optic capture.
Thank you very much. Well discussed. So thanks, Dr. Fazli. Look forward to having you in more of our CMEs. We shall now go on to our next speaker, Dr. Alok Sati, a leading cornea and refractive surgeon from Armed Forces, New Delhi, an academician and a popular teacher who is going to show us a rare event with its own pearl of wisdom. On to you, Dr. Alok. Dr. Alok?
Yeah, can you hear me? Can you see the video?
I can hear. No,
Yeah.
you have to click open. We can see the screen of that intracorneal implantation. You have to click it open.
Your folder is seen, cataract webinar.
Folder is seen.
Okay, just hold on. I think there is some problem.
I think you have to unshare, open the presentation, and
then share.
Yeah. Yeah, now I'm going to share the screen.
First, you open your video. Yeah.
Can you see that? Now I'll click it.
Yeah.
Here. Yeah. See the video now?
No. It won't open like that.
First, Alok, and then share. If you
First,
share,
you open your video, and then you have to share.
Just one sec, ma'am. Actually, it's not happening.
You stop sharing now, and
Yeah.
then open that video, and then share. I think we'll have to insist on everybody to open their videos within that half an hour before we start our webinar. Harshul, it's a message for us.
Yeah, can now.
So first open your presentation, then do the screen share.
Open your presentation, Dr. Alok. Stop sharing.
Yeah, it's basically a video, ma'am.
open your video. Open video, pause, and then share, and then play.
Dr. Alok, can you just stop sharing your screen? I'll play it for you.
Yeah. Thank you very much.
Do that. Yeah.
Do that.
You stop sharing your screen.
You can narrate it.
Yeah.
Yeah. 1 minute.
Just a minute.
So meanwhile,
Just
Dr. Ramamurthy is there. I would like to ask him, and also Dr. Suhas Haldipurkar sir, do you prophylactically place CTR in pseudo-exfoliation syndrome even if you don't encounter any zonular weakness?
Yes, I would.
Dr. Ramamurthy?
No, I don't. I mean, I don't think, if the zonulopathy is going to be progressive, just a CTR is going to prevent that. That will anyway prolapse with the bag. So if it is obviously prolapsing, then we have to deal with it, but not just because pseudo-exfoliation, I don't please it.
I do it for a different reason. When you put an endocapsular ring, you kind of stretch the bag. So in the initial period when your rhexis is in the process of getting fibrosed, if it gets fibrosed, it puts an additional pull on the zonules to get centerwards. So if you put a ring, I presume it would to some extent help you along with posterior capsular polishing to keep the capsular rhexis from phimosing, and that's a big advantage, especially in a weak zonal cases.
Valid point, Suhas. I mean, do you think polishing of the rim of the anterior capsule would help? And the second thing is, one more reason why what you do should be done towards the end of the case when you're removing the last fragment, these capsules also tend to trampoline. And maybe once you put an endocapsular ring, then it stretches it out and lessens the chances.
Yes.
I think it's also important to make a larger rhexis in these pseudo-exfoliative cases. And that should be even more important than actually placing a CTR for all cases. I don't know. That's how I look at it. I would.
Not all cases, but if you have a pseudo-exfoliation, which is can be demonstrated on the table, probably it doesn't hurt to put a ring.
Okay.
Yes.
Can you see the presentation?
Yeah,
Yes,
I
you
can hear you.
Start playing.
Yeah.
You can start.
Yeah.
You can start.
Yeah, this is one of the rarest of rare complication that I'm going to highlight after such a vast discussion. What is this? You can see very well. This is basically a hydrophilic lens which is inside corneal stroma. So I'm trying to remove it and see how difficult it is. Even, plantation would have been much difficult, by the surgeon, but obviously the removal is much more difficult. So the basic purpose of presenting it is to show that this complication also does exist in today's scenario, because after 17 years of practice, I'm seeing it for the first time.
All of us are seeing it for the first time.
So I think this is because of a mismatch between the incision size that the surgeon might have made and the cartridge. That's what I can make out. So since this is the rarest of complications, so this is what I am presenting to you all. And you can see how difficult it is even to remove from the corneal stroma. So I have to literally, extend the incision through which the IOL went inside. And mark my word, this is not hydrophobic lens. This is hydrophilic lens. And this is from Bosch and Lomb. 4 haptic. No financial interest. You can very well see the gap. There's a gap in the intralamellar stroma, which you can very well see. So even the rarest thing does exist today. And that's the aim of presentation.
Thank you very much, Dr. Alok, for bringing out one more point for us in this very relevant webinar. So I think, I can only imagine that the surgeon would have been looking at a wound-assisted implantation.
Correct.
But then what is most important is we should always be conscious that the incision size should be bigger than the cartridge size. And if that becomes smaller, then you could, very rarely extreme force as much could have happened this manner. So it's very important that it's safer to err to a larger incision for then go into a smaller incision for that astigmatic impact of what we say. So we need to be very clear as to how a wound assisted incision surgery has to be done or hydroimplantation has to be done, and what should be the cartridge size and what is the size of your IOL and the incision. I think though a very basic, simple step compared to the gymnastics which you have done in the eye, I think we need to keep all this in mind, and that was a very good video which told us about it all. Any thoughts, expert panel?
Look,
Harshal?
I just want to know one thing. Was it done at your place or was it done elsewhere? Because really there is a huge amount of force, to penetrate these. I mean, you are a corneal surgeon yourself, and to penetrate the corneal stroma. And if it is anterior, of course, it cannot be. But by the look of it, it looked as though it was in the posterior stroma, not in the anterior stroma.
Yeah, it was. Even the OCT suggests so, ma'am, because it is somewhere between the junction of middle stroma and the posterior stroma. Because I could measure that size also after removing the lens next day, and I could see that there was around 75 micron posterior layer thickness was there.
I think, ma'am, I can't imagine the amount of force which would have been required to put this IOL in the layers of
and
cornea.
that too, what is the most surprising is it is the hydrophilic lens.
Yeah.
Lens.
That's exactly what I was also thinking.
Yeah, that is why I presented it to this forum, that such thing also exists on Earth.
No, we have seen it before also. Dr. Arun
Yes.
Jain has also shown.
Yes, I've also seen it before.
So many years,
Yeah.
yes.
Yeah.
But it's very unusual.
But that was, I think, a decade ago.
Yeah.
This is latest.
Yeah, yeah.
I think I would really like to see which gym this guy goes to with the primary surgeon. I mean, must be a real powerful guy.
True.
After this,
After all this, sorry?
You implanted another lens, obviously. After
Yeah.
And you implanted a multifocal lens. You implanted a multifocal. I really appreciate your guts.
Yeah. Ma'am, in addition to the size of the wound, what you mentioned, it is the bevel.
Bevel.
Things should not be done just blind.
Yeah.
For the viewers, it is the bevel should be seen inside the wound.
In the incision.
Yeah,
Yes.
in the incision.
Clear in the
yes.
Better than
probably even the haptic should be folded on the IOL, and the bevel should be the incision tip, and then only you can inject it in that manner.
And especially when doing a wound assisted insertion, better to have a counter pressure also. Sometimes the pressure at the wound may cause the injector to withdraw a bit, and the surgeon still pushing it in intrastromally. So better not to have a complication like this.
I think the basic of presenting this is to ensure that the size of haptic should match with that of with the incision, because especially if you're doing in the initial phase of your career, that's what.
I think the more important complication would be a DM detachment more than something like this. And maybe since you have the time, Namrata can tell something about how to avoid this in these cases. She's the cornea specialist in the panel.
So I think you're quite right, Dr. Ramamurthy. In case there was a DM detachment, then it would have been more difficult to salvage, because any separation which is there in the stroma is more forgiving than the separation which occurs at the level of the Descemet's membrane. And Descemet's membrane detachment, I think there are some eyes which are prone to it, some which would be genetically predisposed, some like Fuchs, some like even at the genetic level, which has big H3 proteins, etc. So you need to know about it, because you need to counsel your patient that such a thing may occur, a DMD may occur if the Descemet's is congenitally loose or weak, so that the patient knows that this is going to happen and doesn't blame you for it. And of course, I think all the points were really well said, that your incision, there's no need to force yourself to do a wound assisted implantation of the lens if you are in the early phase of your learning of phacoemulsification and intraocular lens implantation. you can increase the wound slightly and then go and actually go inside and ensure that you are not going to be ripping the Descemet's membrane. There are instances when the IOL with the cartridge only, the Descemet's membrane at the wound side gets detached, and if it does occur, it is best that especially the wound side Descemet's membrane detachment, that you put in a leave in air at least at the end of the surgery, so that it will get attached. Most of them would get attached by week 1, and we had done this study where we had prospectively followed cases with wound side Descemet membrane detachment, whether at side port or main wound, and by day 7 almost all of them would get attached, and you don't have to do anything further than that. So either you can leave a air bubble there. Again, the problem would be if it's a superior incision, it's good. If there's a detachment there, I mean, it's not good, but it's better than having it temporarily, because the bubble is not going to last there for too long at the temporal side. Superiorly, when the patient sits, then the bubble moves up, and then that way it is much better. So probably if you're doing a fuchs, it's always good to make a superior incision, or if you're doing a case of weak Descemet's membrane, again it is always good to make a superior incision than to make a temporal incision.
And
Actually,
probably
the last year,
probably a wound assisted surgery should also not be done in cases like if there's a PCR or there is a capsule problem like a rexus extension or a loose bag, or even in a small pupil. Maybe these are situations where we should not even try a wound assisted implantation.
in the last year or so, I've actually increased my wound as an incision size from 2.2 to 2.4. And I find that whether it's phaco probe or introduction of intraocular lenses, everything is so much more comfortable and convenient. And it's well proven that the surgically induced astigmatism of a 2.4 millimeter incision is almost the same as a 2.2 millimeter. So I think no longer that fascination towards going sub 2 millimeter and making it smaller and smaller is there. As Namrata so nicely pointed out, making an adequate incision is what is important. And maybe even if I'm thinking about a micro incision cataract surgery in today's world, maybe a 2.4 might be a good way to go.
I totally
Dr. Harshul,
Yes, ma'am.
can you show the last video?
Yeah. We have 2 videos, ma'am. Dr. Ritesh and Dr. Raju. So I'll be sharing Dr. Ritesh Pal video. Yeah, it has a narration.
Yes. Yes, Dr. Paul.
So yes. So
that has a
let's
voice
see.
overlay. Show that. Yeah.
Yes, it's a video about spontaneous
Yes, that's
rupture.
Yes,
it has a narration in it,
Yes,
and let's
yes.
then discuss with our expert panel.
Yeah.
Okay, so
No, you're showing. Show, doctor.
Yeah. I'm sharing that, ma'am. So this.
As Edwin Murphy once said, everything that has to go wrong always does. During cataract surgery, the posterior capsule acts as a barrier between the anterior and posterior compartments. An equalization of pressure between the two compartments is of utmost importance to maintain the integrity of this barrier. Any imbalance in pressure between the two compartments will lead to a breach in the barrier. In the first case, we see a routine cataract surgery being performed. After nucleus emulsification is complete, the surgeon notices a spontaneously occurring PCR, which within the blink of an eye extends to the periphery. There is momentary shock. but the surgeon assesses that the anterior vitreous phase is largely undisturbed. The chamber is adequately filled with OVD and cortical removal is attempted. Which was successful. The chamber is once more filled with OVD and the intraocular lens is implanted in the bag. The haptics are placed such that it stabilizes the PCR. In the second case, we see a posterior polar cataract, successful nuclear removal, removal of the cortex begins, and is completed without any roadblocks. Notice that on the surgeon's right hand is the irrigation probe. After the cortical removal was complete, the surgeon is now ready to implant the intraocular lens. However, he notices a spontaneously occurred PCR. In both cases, we see an imbalance in pressure in between the two compartments, leading to a breach in the capsule. In the first case, we propose a theory that due to inadequately filled anterior chamber with OVD after removal of the nucleus, along with an increase in the positive vitreous pressure, there was a breach in the capsule.
Yes.
Actually, in these two videos, Harshu,
Yes.
I felt that the first case having that kind of thing could have been a sort of an occult PPC or maybe a lens touch if there had been an earlier VR surgery, wherein you can get this characteristic splitting of the capsule or maybe a traumatic cataract. But it just cannot happen a spontaneous rupture unless in some of these specific cases. Maybe a anterior chamber shallowing could have triggered it off. And in the second case, again, I think any polar cataract, even PC polishing is not advised. Sometimes even a stromal hydration wherein there is an increase in the intra capsule pressure could, a weak dehiscent capsule can give way. So I think there is the spontaneous rupture is not there. There has been some kind of an intraocular pressure gradient which has happened, which creates this kind of a split.
Yeah.
I agree with you, ma'am. I agree with you, ma'am. Because the nomenclature spontaneous is something which I really disagree because it's iatrogenic. It happened when fluidics were within the eye.
Yeah.
So even during hydration of the wound, PC rupture can happen.
Yes.
Dr. Suhas, your views, sir?
This is a classic case of a micro puncture that occurred while you are phacoing, and when the AC is shallow, it gave it full, chance for pressure gradient to change,
To come.
and it just opened up. It just
Yeah.
And anything else anybody has to add? We go on to the next video.
What you said was
Namrata ma'am.
I think what I was saying and what sir is also saying is absolutely correct. The second case was posterior polar cataract. So posterior polar cataract is known to have fragile capsule and spontaneous distance can occur. But the first case obviously had some kind of a touch or was post surgery, and so that is why it occurred.
Yeah. And moreover, the anti-chamber was not maintained before withdrawing.
It's not spontaneous, it's iatrogenic.
What I feel that you call it a spontaneous because you don't find any obvious reasons. Because I have also a lot of spontaneous, actually 3 in my, I have got a video. That is, everything is done, IL inserted, everything is fine. You are about to hydrate the margin and you see that there's a absolutely very nice PCR happening longitudinally. I've got 3 pieces videoed, yeah.
The take-home message from this video might be, especially from the first video, there was a small rupture, maybe must have been iatrogenic, and then subsequently, literally, we were waiting for the capsule to open up. Maybe at that time, a dispositive viscoelastic had been injected inside to maintain the anterior chamber, push up the anterior chamber pressure. The extension of the capsular end could have been arrested, but possible that the surgeon was not expecting this to happen.
Yeah, true.
A small point, not
yes.
for this particular thing, ma'am, but I remember clearly Dr. Samresh presenting a video in one of the conferences wherein he's completed his surgery, done everything for the posterior polar, but once he's hydrating the wound and it just went off.
Yeah, that's what. So the hydrate.
Be careful, even with the hydration.
Any hydrostatic pressure change can bring on PCR. Yeah.
And that's because of the undue pressure, no? So they all, in fact, they are all iatrogenic. Dr. Lionel is right. Yes. Yes. So we always should be careful till the end. It's not over till it's over.
Yeah.
Okay.
Will remove speculum?
Yeah. Speculum, yes. Harshul, can you show the last video and give the voice?
Yes. Yes, ma'am.
Gives away.
So this is the video from Dr. Gopal Raju. So this is the case which was going on normally. He completed the capsular axis. The cataract was of grade 2 nuclear sclerosis. He's chopping at this point of time. And I feel at this point, somehow he ruptured the anterior capsule. So you can see a tear in the anterior capsule there opposite the phaco probe. So luckily this tear didn't extend into equator or beyond that. So we can see the edges of the tear, but he completes the cortical cleanup, put OVD, and put a 3-piece IOL in the capsular bag. So here goes the leading haptic, and the trailing haptic is dialed in the capsular bag. And he takes off all the OVD, washes it out, and completes the case. Now the point to discuss here, I like to ask the expert panel is, of course, extension can occur if we are not careful enough from the chopper. So should we try to salvage this anti-capsule tear which is there, or leave it like this? Dr. Ramamurthy, what would you have preferred?
No, I think he handled it quite well to the best of his abilities. It's an unfortunate occurrence. And as you rightly said, you're always concerned about the wraparound, that it is going all around. And you have to be extremely careful of not stressing the capsular bag too much. And in case I'm doing a stop and chop, I would split the nucleus at 90 degrees to the axis of where the tear has occurred, so that I don't apply any pressure in that area. And in case it's a very soft cataract, maybe a good idea, as we already discussed, to prolapse the entire nucleus out of the bag and then emulsify it in the anterior chamber, and so that you don't stress the capsular bag in any way. All along, you have to be cognizant of the fact that there's a discontinuity in the capsular rim, and the basic thing you need to avoid is it spreading onto the posterior capsule. Sometimes if it is just a tag, and then it's always a good idea to use a rhexis forceps or even an aspiration cannula to round it off. And otherwise, that weak area at any step of the phacosurgery can spread over.
Actually, it's most important to keep the anterior chamber stable if there is a rhexis extension. And besides all the points he said, that now we popularly talk of an inverted flap or an inverted flap, that an inverted flap would not extend and an inverted flap is likely to extend. Maybe that concept could be kept in mind. And the last thing is the intraocular lens implantation. We keep the haptics away from the area of extension. Maybe all that sums it.
To us, sir, what would you prefer, a single piece IOL in a case like this where the anti-capsule tear is in this situation, or a 3-piece IOL? Because if you try to implant 3-piece IOL, you may extend it, while dialing the 3-piece IOL. So what would you prefer?
Thank you, Harshal. See, my concept is this: when you have a tear like that, not all the cases the tear will go to the periphery. It very much depends upon the strength and the positioning of the zonules at that state. There are cases where you have a tear and you complete your case like normal, but in others, even before you have done anything, the tear has already crossed to the posterior capsule. Now, this was probably a case where the zonules were holding on, so the stretch wasn't going into the periphery. Now, secondly, having been lucky there, I would never think of putting a 3-piece in this eye. And if I had to put a 3-piece, I would always put it in sulcus. For me, in this case, single piece in the back is the lens of choice.
I think to this, I would just like to add, when you're putting viscoelastic, also be very careful. Don't put too much, because that can also extend the cause extension of the end. So just optimal amount of viscoelastic so that it doesn't overfill and cause the PC to extend. And low parameters, when you have that thing, then all your parameters have to come down. I think Chitra very nicely said that never allow your AC to be shallow, because that is going to increase the extent of the rib.
Also, ma'am, while doing the last bit of that IA, especially around that neck, we have to be very careful there. Maybe you can, leave that small bit, put the lens, and then take it out. Maybe.
I think.
What do you have against a 3-piece lens? Is it because you think it's more explosive opening up, or what is the reason that in these cases you totally stay away from 3-piece?
No, because anyway, you're going to put the lens in the opposite direction. So the 3-piece lens already has some amount of stretch, which is more than a single piece. So if there's a tear, this single piece is going to just repeat more. I mean, that is my understanding. You can correct me.
Yes, that is a food for thought. Agree. So,
and the single piece hydrophobic, they open in very small configuration. No, when you inject it, you can rotate it to be perpendicular to the tear, and then the haptics will open.
I think we don't have too many studies comparing the two, but it would be worth doing one. First, have so many ribs, and then put single piece or 3 piece.
Only you can do it, brother.
Good. Okay. So I think we've had discussed it all, and I'm so thankful for the speakers and the expert panel being there. So I will come with my concluding remarks. I believe it's been an immensely gratifying webinar, and I'm sure we've all gained very well from the experience. My deepest gratitude to the wonderful expert panel, each and every one of them, a great set of speakers, and the joy with which each of them participated, and even the connection which they had. A very special thanks to Harshul for being a wonderful moderator and even taking over one's talk in the last minute. My thanks to the admin teams headed by Kripal, Sai, and Manjula from Neurotech for their constant support and participation. Mr. Sunil, who has been a wonderful webinar administrator and takes great involvement from before. Thank you very much. And of course, Entod for being there. Constant sponsors and encouraging us to spread our educative material all through the corners of the country. And most importantly, my own wonderful ARC team, who are always their big support, and you would have definitely seen 2 of them speaking so well in this meeting itself. And finally, and most importantly, our thanks to our attendees, whose participation is what gives us the impetus to keep coming back to you week in, week after. Thank you, one and all. Thank you.
Big thanks to you too, ma'am.
Thank you so much, ma'am.
Bye-bye.
Thank you. Thank you very much. Thank you, Lionel.
Great webinar.
Thank you.
Thank you.
Thank you. Thanks, Namrata. Thanks, Dr.
Bye.
Suhas.
Thank you, ma'am.
Thank you.
So much.
Thank you, Anaga.
Thank you.
Thank you.